Travis. Welcome back. This was supposed to be on the first one. This is me. Don't really care. So basically, anatomy of the knee, evaluation of the knee. Didn't we do it with the lights off last time? Can we do that again? She's laughing. That's not fun. Okay. So the knee, like I told you before, the knee is a lot easier to understand than the shoulder. The shoulder has a bunch of stuff that even after you go through school, you still don't understand. The knee is pretty easy, like I said. 3 bones, 4 ligaments, 2 meniscus, and some muscles. So you guys are good enough with anatomy, so I don't need to go over all of this with you unless you just want me to. Evaluation of the knee. So this one was this actually talk was put together by somebody who was a little bit more type A than I, which is pretty hard to do. So some of this stuff is once again very, very like, oh my gosh, you're telling them how to lay down on the table. So you lay them down on the table, affected extremity closest to you, minimal movement on the part of the patient. Once again, that's whenever I was talking about the other day, don't jostle them around a lot, especially if they're hurting a lot. Perform everything bilaterally. This is why. Remember the other day, did I have you guys do the thing where you put your thumb on your forearm? Can we not do that to examine for ligamentous laxity? Oh my God. So everybody do this. Put your arm up, put it right like this. Take this hand and let it drop. Now take your other index finger and put it on your thumb and see if you can touch your forearm. Don't break your thumb in trying to do so, you don't get a prize. Who can do it? Okay, so that is how we test for ligamentous laxity. Those people, and the only reason why this is important is because those people are usually hired to sprain their ankles, dislocate their shoulders, tear stuff, right? Because their ligaments are stretchier than ours are, so especially shoulders. So that's why we always say examine everything bilaterally, because if you have somebody who comes in and their ligaments are looser than everybody else's, that's why you want to check it. Because if you do an anterior drawer test on somebody to test for an ACL and it slides out a little bit, you're going to go, oh my God, this is loose. Well, check their other side, because if they have that other side is probably going to be as loose. So what you need to see is if it's looser than anything else. This is also a great pearl to take when it comes to radiology, especially of kids. Always, if you're concerned about something, always x-ray the other side. There's nothing better than doing that. So if you go, oh my gosh, I think I found a skiffy. Have you guys learned hip anatomy yet? No. Slip calf femoral epiphysis on kids. It's basically where their hip, yeah, you'll get it, you'll hear it. But anyway, x-ray the other side. If all else fails, x-ray the other side, okay? So once again, perform everything bilaterally. And to have it performing that way, and I always do this, it takes a little bit longer, but if you get quick at it, it won't take that bad. That was on there. Observation, deformity, open wounds, abrasions, 3 E's, edema, effusion, and ecchymosis. What's the difference in edema and effusion? Don't be shy. So let's do this. Let's start off easy. What's edema? Swelling. What's an effusion? Swelling inside the joint. So if I have a big knee effusion, it means my knee is very swollen. If I have something like patellar bursitis or something like that, that's going to be outside the joint, extraarticular, so that's a little bit different, okay? Loss of contours, so this means like if you ever sprained your ankle so bad that you look down, you can't see either of your malleolus, like, right? I mean, that's loss of contours. You dislocate your kneecap, it's not it's the loss of contour. Color changes, self-explanatory. P is for palpation. I didn't make up this hops thing, so don't think I'm really genius about it. It's just on here. Palpation, effusion versus edema. That's the other thing is if it's edema, sometimes you can. Has anybody ever seen patellar bursitis or olecranon bursitis? Yeah. You can kind of play with it like a little water balloon. So that's why. I mean, you think you'll do it. I promise. But effusion versus edema. If it's swelling in, or if it's an effusion, you can't do that. It's inside their joint capsule. It isn't moving. Crepitus during range of motion, mechanical symptoms, popping, locking, clicking, catching. This right here on a knee, in my opinion, is a meniscal tear until proven otherwise. They call them mechanical symptoms. So what you'll do is when you're dictating, if somebody comes in, of course you'll say, well, positive medial McMurray's, positive medial Apley's, and then under the way that the ICD-10, and you guys haven't known this yet, but anybody who's been out and working, the ICD-10 took something that was the ICD-9 and that was kind of understandable, and then it said, okay, we're going to make this significantly harder where you have to have paid people come in and explain it. So instead, the other part now too is if she comes in and I think she has a meniscal tear, if I put I think she has a meniscal tear, they will bill her as she has a meniscal tear. Well, the hard part is once you give her that diagnosis, you can't get it back off. So, once again, that's whenever we'll start being a little bit more vague about it. Mechanical symptoms, internal derangement, sprain, strain. Everybody leaves my office has a sprain, strain until we get the MRI. unless it's a bad fracture, just because it'll hose them. Pain over the anatomic landmarks. Special test, we'll go through these: patellar apprehension, meniscal injury, Apley's, McMurray's, deep squat. This one right here is more of a book thing. I mean, if somebody has a painful knee and they're in the CU, you're probably not going to want to have them walk like a duck. Plus, if they fall in your clinic, then you're liable. Ligamentous laxity, varus and valgus stress, we'll go through that. Lockman's anterior posterior joint pivot shift. This pivot shift, and we'll cover this a little bit later, this is more of a surgical thing because it's not fun to do if the patient's awake, and they will not enjoy you doing that. So that's more of a, if you were in surgery and the meniscus or the MRI said you had an ACL tear, and then we go in and put the scope in and it is not torn, that's when you do a pivot shift, and I'll explain that. Okay, so my sequence. Once again, you guys saw my whole shoulder exam, right? You look, you feel, you test their range of motion, test their strength, and then do your special test. So it's the same thing. Palpate for effusion versus edema, patellar apprehension, check range of motion passively and actively, pain with terminal end range of motion, crepitus mechanical. Pain with terminal range of motion is usually a meniscal tear. If you have someone who has a posterior horn meniscal tear, they will usually have more discomfort with hyperflexion of the knee. That's why the duck walk hurts, because they're hyperflexing their knee. Palpate the joint line and anatomical landmarks in relation to the joint line. Meniscal testing, ligamentous testing. So other special tests as needed. And that's the whole thing is when you guys are going through these exams where somebody's watching you, in your head you're doing this check sheet. You're like, oh, did I test for this? Did I test for this? So the thing about it is when you get to the other special tests, on my stuff, like if I'm worried you have a quadriceps tear, I'm going to do all that other stuff because I'm a creature of habit and I like routines. But at the end of it, we're going to go back and test for the quadriceps. Can you fully extend your leg sitting on the side of the table? Do you have pain with active resisted knee extension, stuff like that? So just go through, once again, go through the normal test and then bounce back if you're concerned about something. How many people do this? How many people, when you take your test for PA school, you go through the whole test and you make little marks by the ones that you're not sure and you go back to do those again? That's all you're doing, right? So if you say, look, I'm a little bit concerned about this. I'm a little bit concerned that they have a meniscal tear. I'm going to go ahead and do my whole exam, and then I'm going to go back and do that again. Okay. So, knee injuries and pathology. Bursitis. Small inflammation of small fluid-filled sacs present at the points of high friction where the tendon passes over a bony prominence. Most common locations around the knee, prepatellar, and pes anserine. I'll tell you what, I give a pes anserine shot every single day of my life. And a lot of times they're sent over as knee pain. Now the thing about the pes anserine, and I'll show you this, is it's below your knee, so you have to make really for sure that the people who are on your patients to distinguish between intraarticular and extraarticular knee pathology, and we'll go through that. 40-year-old male construction worker presents to your clinic for anterior knee pain after swelling and kneeling on a hard floor. So these are sometimes and usually going to be manual labor folks, people who install tile, people who install floors, roofers, people or carpet layers, stuff like that, and or people who have a pastime or a hobby that they do where they're more down on their hands and knees. I can't think of one, but there's something. What's that? Gardening. That's a great one. Or mechanics, because they're always kneeling around in their cars. So bursitis, once again, concern over swelling may traumatic or chronic insidious onset, little of loss of function. So remember, so you've got your pes anserine bursa, which is right here. You've got your deep infrapatellar bursa, you've got your prepatellar bursa, and then you have your suprapatellar bursa. So basically, somebody was nice enough to name them after where they literally live. So just kind of follow that. You can have this posterior, the popliteal cyst, or also called a Baker cyst. And remember this, 9 times out of 10, if you have a Baker cyst, you've got a meniscal tear. That's how it works. So anytime that I see, because usually on MRIs, they'll say, patient has a posterior horn medial meniscal tear, strain of their MCL, blah, 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 and then everybody puts it on the bottom. Oh yeah, by the way, they have a Baker cyst, because a Baker cyst is not something that we're going to cut out or drain. Don't ever let anybody, if you hurt your knee, do not ever let anybody drain or cut out a Baker cyst. Why is that? Now don't get me wrong, there's some very, very educated doctors who will tell you that you need to do that, but why? Yeah, what's back there, right? Popliteal nerve, artery, vein, right? So you want to have some foot drop, it's not as fun as it sounds. So let's not do that. The other reason is the analogy that I give my patients as far as the Baker cyst is if I have a leak in the roof right here, and I put a water bucket right here, and that water bucket is the Baker cyst, and I keep draining that, right? Well, is that going to fix the leak in the roof? No, so you can take care of that Baker cyst all you want, which I highly recommend not doing, because after you get your meniscal tear, it'll either resolve on its own or it will burst. And they'll say, man, it's kind of funny, I felt this pop on the back of my knee, and it felt like water was running down my leg, but I wasn't in the shower. That's what a ruptured Baker cyst feels like. Okay, so see this? Now, if this was in real life, honest to God, you can sit there and do this with it. It'll just kind of, like a waterbed almost, right? So there's your prepatellar bursitis, watery feeling and swelling, extraarticular. So remember, anytime you're talking about things, you need me?
I'll grab my bag.
Oh, yeah. I was wondering who that was. It's heavy duty.
It is heavy duty. Thanks, appreciate it. Sorry to interrupt, Travis.
No, no worries, we're all. So, watery feeling, extraarticular pain. So intraarticular means inside the joint, extraarticular is outside the joint. Pes anserine bursitis does not swell like this. You will never have somebody come in that has one of those. Those are more of a feeling type thing, and I'll show you guys how to do that whenever I show you my exam at the end of the day. Pain with active range of motion, increased friction over the inflamed bursa, otherwise their exam is normal. So when you're doing all of your special tests, your anterior drawer, posterior drawer, MCL, LCL laxity, things like that, all those things are going to be normal because this is not inside the knee. It's just going to be puffed up on the outside of the knee. I'll give you extra credit to anybody who can name the 3 pes anserine tendons. One. He's close. You got 2. And what? Nope.
No, sorry.
Bursitis, sartorius, and semi-tendinosus.
She got it. She got it. Semi-T. Tendinosis, not membranosis. But yeah, semi-T. So whenever people have a semi-T ACL surgery, has anybody ever done one of those? ACL surgery that was done with a semi-T instead of a bone-tendon bone or a cadaveric graft? You did? You had a semi-T? So that's what they do. So pes anserine in Latin means goose's foot, because I guess geese have pieces, have 3. So they come down the 3 right here, right? So that's what they do is they take that and they divide the 3 and they strip that up. And that's how they make your new ACL. It looks like a fireplace poker with a little razor blade on it. And they put it through there and they just strip it straight up your leg. That's why, did you have trouble with jumping for a little while after that? Like some internal knee pain, hamstring pain?
Yeah.
There you go. Because they stripped that tendon right here. Workup, most often clinical diagnosis, maybe an MRI if you see something else going on. Radiographs will not show anything unless it's calcific. Treatment, conservative, RISE protocol, antibiotics for septic bursitis. So this is where kind of the rubber meets the road with bursitis. If somebody comes in and they're complaining of temperatures over 101.5, man, remember, they're all going to be warm because it's body fluid. Body fluid's warm, there's more body fluid, it's warm. But if that thing is red and they won't let you move their knee, they won't let it touch it or anything like that, and I don't care if this is on their knee, their elbow, their shoulder, or whatever, if it is warm and red, that thing needs to more than likely come out of there. So what we do in the clinic is we drain them, we send it off to lab, and then we see what all it shows. And usually after we've drained it, we'll go ahead and start them on some antibiotics, just because if you put them on the antibiotics before you drain it, of course that can skew things. Invasive aspiration, prepatellar. So a lot of times what will happen is primary care physicians won't, or PAs or nurse practitioners or providers won't feel comfortable draining these. These are ridiculously easy to drain. It's a big, huge water balloon in front of you, and you just make sure you stay away from the nerves. But this is one of those things that by simply draining it alone, you can give them relief. You walk right out of the clinic. Thanks, man. High five. See you later. Bye. The rule of thumb on that is you will drain it 3 times. Because after 3 times, if it comes back a 4th time, we are cutting it out. And the reasoning on that is, every time I take something and put it inside your body, there's a risk of infection, right? So the more we keep doing that, the higher risk of that taking that non-infected prepatellar bursa or olecranon bursitis and making it infected. So our rule of thumb, and this isn't universal across orthopedics, but it pretty much is that after we drain something 3 times, the 4th time it's coming out. Because if it isn't infected, it can get that way, even under sterile technique. Bursectomy for recalcitrant swelling and infection or pain. So once again, the number of these that actually go to the operative room, I'll tell you maybe, let's say 2 out of 50 maybe, and those are the only ones usually that are infected. Any questions on bursitis before we go on? So remember, it's going to be a swelling that you can, what was it called, allotment? I think you can kind of move back and forth and all that. But the biggest thing is the rest of their knee exam is normal. Okay. So ligament injury, everybody remember when Tom Brady got that right there? Ouch, because there's his foot going the wrong direction. So ligament injuries, injury to one of the 4 main stabilizing ligaments of the knee, MCL, ACL, PCL, LCL, you guys know those. There is very, very, very rare to see a PCL injury. PCL injuries and LCL injuries are some of the most rare. ACL and MCL are very, very common, of course, and having more than one is usually due to some type of trauma. The only time I've ever seen all four was a lady got hit in a Volkswagen by a semi-truck going head-on, and she actually tore all four of hers. So grade on a scale of 1 to 3, once again, we talked about this, I think, with the shoulder, but if this is a ligament, this is a grade 1 sprain where you make it mad. This is a grade 2, this is a grade 3. So grade 2, you can think of it as a partial tearing, 1 is a stretching, and 3 is it's done, it's in half, okay? MCL, competitive football player, just like you saw Tom there, it's an outside injury. So a lot of your defensive ends and things like that, they're sitting there and then they'll have a pulling guard come hit their knee. So it's basically or a flying karate chop. But you can always, it's any kind of a valgus stress, right? So that's usually where you'll hear it. Just to let you know, an MCL is the only injury that I will not let somebody continue to practice on or play on. So if I'm in a football game and they come over and they go, hey, I think I tore my MCL, we're going to check them, and I will not let somebody continue on that. ACL, it's up to you and your parents. PCL, once again, it's ridiculously uncommon. And LCL, that would maybe be a close second to the MCL. Most common ligament injury to the knee, although not the most publicized. Everybody hears of their ACLs because they get the surgery. They have to miss 6 months of football. MCLs, you're in a brace and you're back to playing football in roughly 2 months, tops, maybe 3. Occurs when a valgus force is placed on the knee. Medial sided knee pain, onset of effusion usually 1 to 4 hours. Who said they tore their ACL? How fast did it swell up? Super fast? Yeah, and that's why you always hear people wanting to get ice on a knee injury real fast, because ACLs, remember there's that artery that goes down the middle of your ACL, so if it's torn it pumps blood in your knee and your knee blows up real big. So if you think somebody tore an ACL and you're on the sideline, put some ice on it. Onset of effusion, remember effusion is swelling inside the knee. Inability to bear weight or instability with weight bearing. Knee gave way or knee buckled. And they'll say that. They'll say, whenever I put my foot down, it feels like my knee wants to buckle towards the medial aspect or the inner aspect. Medial pain at the origin, mid-substance, or insertion. So that's why whenever I show you my exam, you'll see that I palpate the proximal, the middle third, which is at the joint line, and then below. Laxity during varus and valgus stressing, or valgus stressing, excuse me, not varus, I misspoke. Valgus stressing. Do not admit other special tests after having a positive valgus stress. The reason on that is what if they have an ACL-MCL combo, right? Does anybody know the unhappy triad? Yep, what'd you say? What was the last part? Okay, so for those of you who didn't hear, ACL, MCL, medial meniscal tear, right? So it's kind of one of those things like if you look at an x-ray and you jump straight to the first thing you saw but you missed something else. So don't do that. That's why I'm talking about just being methodical through your testing. Did anybody ever hear the gorilla study? Doctor, you may have heard of that with the radiologist. So what they were doing is they were trying to talk to or see how much people miss stuff on x-rays. So they gave a group of radiologists a known cancer or something in the chest, and on a chest x-ray, and you know like when you go to the store and you have those little 25-cent things and a little egg falls out, they got a little plastic gorilla that was about that big. They put it on every one of them, and over half of them didn't see it. So if you're focused at it, and then when they said, did you see the gorilla? And they're like, what gorilla? And then they showed them again, they're like, I'll be damned, look at that, there's a gorilla on there. There's a pretty cool thing on that on YouTube with bouncing of balls, and they have these people in white and these people in black, and they'll have him bouncing the balls, and they can only bounce to each other, and they're so focused on that, literally a man, and a full-size man like me runs across the screen in a gorilla suit and waves his arms, half of them didn't see it. So once again, my reason in being methodical, whether you're looking at an x-ray or whether you're doing a test, if you skip stuff, you may skip over the one test you needed to catch. So do everything in order. Be as anal as you want to be. Just keep doing it in the same order, because if you get off of that, it's going to be hard to remember which one you did and didn't do. And if you keep stutter stepping and going back, your patient's going to go, does this dude even know what he's doing? Or young lady, excuse me. So don't miss other special testing. Now the one thing about a varus and valgus stress is, when your leg is in full extension and you try to do a test on these people, they can lock up their quadriceps and give you a false sense of security. So what you do is, and I'll show you how to do it here in a little bit if Sally hasn't already, I like to do my valgus and varus testing with their foot in my armpit while I'm standing up. So what I'll do is I'll put my other hand underneath and bend their knee to a 30-degree angle. If you will bend their knee to a 30-degree angle, they can't lock up their knee by flexing their quad. So therefore you can get a better valgus testing. So if I dictate a patient's knee, I will say there was no ligamentous laxity at 0 and 30 degrees. That way if it's ever reviewed, God forbid, they go, hey, this guy knows what he's doing because he did it at 0 and 30 degrees. Because they will fake you out all the time if you do them in full extension. You'll miss it a bunch. Grading the varus and valgus stress, always compared to contralateral side. So this guy's got it going on, right? So he's doing it kind of straight right there, but then if he does it up on the table, you can see him dropping him off and doing it at 30 degrees right there, because he knows if they lock that quad up in extension, you're going to think their knee's stable all day long. Grade 1, I'll let you guys read that. It's just basically the determining of the layers. But even then, you're not ever going to tell somebody that. You're not going to say you've got a grade 3 MCL sprain or a grade 2. You're going to say, you know what, I'm concerned about this. Let's get you in a flexion extension brace and go get an MRI. Routine radiographs, AP and lateral. May see an avulsion of the attachment sites, maybe not. Physical examination will dictate a further workup. Once again, primary care pants answer is an MRI. An MRI because it shows the soft tissues. Specialty answer, isolated MCL sprain or origin injury does not need an MRI, but in today's day and age, people want to know what's wrong with them. So remember, you go back to your 5 things, right? It doesn't matter what I want them to do. What do you want to do? So if they say, hey, I want an MRI, I'll say, okay, I think it's your MCL, but let's go check it out. So it's okay to tell them what you're leaning towards, just don't make a definitive diagnosis. That's how I do it. It may or not be right or wrong, it's just how I do it, because it's easy to get egg on your face. Yes, any grade 3 injury or questionable meniscal or any other ligament or insertional injury does need an MRI. So once again, if you think something else is going on, you've got to take care of it. Treatment, grade 1 or grade 2, weight bearing is tolerated. These are going to differentiate them in the grades. That is only after an MRI, bless you. Weight bearing is tolerated with or without crutches, a hinged knee brace. So here's a little fun fact. Your MCL is on its fullest tightness, that's not the right way to say it, but you know what I'm talking about, at what degrees? So when is my MCL stretched the most? At what? Just blurt them out, it's fine. What? Extension. Okay, so there's one. So 0 degrees. She's half right. When's the other one? 90. Right? So at 0 degrees and at 9 degrees, that's when my MCL is being pulled the most. So guess where we lock them in their flexion extension? Everybody knows what a flexion extension brace is, right? The one with the dials on the side. 30 degrees. Because that's when your MCL is just chilling out. It's laying in the hammock at 30 degrees. So if something has been injured and you're worried about it and there's stress to it, what do? You put them in something that's going to hold them still and you're going to relax it. So you put them at a 30-degree angle in a flexion extension brace until they go get stuff. Now, if anybody's ever walked around at a 30-degree angle, which kind of makes you look like those little horses that prance, right? I mean, like what do they call them, the show ponies or whatever? It's ridiculously hard to walk like this, right? So what else are you going to give them? Crutches, right? So crutches, MCL brace. That's it. And then go get an MRI, ice, immobilizer, all that stuff. Anti-inflammatories, narcotic pain control, which nowadays is of course frowned upon unless they're dying, and referral to me. Vast majority are non-surgical. Once again, the last time that we fixed an MCL, honestly, I don't remember the last time we did. I even tell our patients that, look, there's a high potential if this is just an MCL, you're not going to have any kind of surgery. So what we do is, just to kind of let you guys know, I don't think it's important for your testing or whatever, but our protocol is they're locked at 30 degrees for 3 weeks. Then we open that same brace for the next 3 weeks. And then after that, you get them in therapy, because you've got to let that thing kind of heal for the first 3 weeks. Multi-ligament or injury or MRI evidence of a distal insertional injury may require surgery. Physical therapy, I told you guys this with the shoulder. Physical therapy is something that you have to almost beg people to do, but once they do it, they're like, dude, thanks, I'm sorry I didn't trust you the first time. 4 to 6 weeks of disability depending upon the severity. Any questions about the MCL? So remember, it almost always doesn't need surgery unless there's 2 other things or 3 other things along with it. You put them in a brace, put them on crutches, go get an MRI. ACL, once again, this is a popular one because of Adrian Peterson and basically anybody else who's ever torn up their knee. Adrian Peterson kind of hosed us in the orthopedics community because he got better really fast because he's freaking Adrian Peterson. So people are like, well, Adrian Peterson got ready and was playing football in 2 months. And I was like, yeah, you're not him, and you can't do that. Provides rotational stability of the knee as well as prevents excess anterior tibial translation on the femur. This one is one of the ones whenever people are coming down off, they get the breakaway, they're dribbling down the court, and they make a stop, and then they go to shoot. It's the deceleration of it that does it. Let me ask you guys a question. On football players, what percentile of ACLs do you think are torn non-contact? 75%. 75% of ACL tears are non-contact. It's the receiver going out in the flats and pivoting and cutting. It's that deceleration going into it. So very, very common not to have it. That's why, who tears more ACLs than anybody? Girl soccer players, girl basketball players, girl racquetball players, which I think that sport's not caught on enough in America, but it's fine. But the point is, now let me ask you this. Do you guys know why females tear their ACL more than males do? Hang on, well, what?
Ligament and like.
Your hips are wider? I wasn't going to really go with that. That's kind of a tap dancing area for me. I'm not going to talk about girls' hips. Here's why. So, A, your femoral notches, right? So your medial lateral femoral condyles, your notch is more narrow. That's, remember, your ACL and your PCL run right up through there, right? So if that's more narrow, it's going to be easier, right? So there's that. She's right. It is the biomechanics of how they land, right? When girls land and guys land, guys usually land with our feet up under us. Girls usually land and they kind of go into this valgus type stress. And what's another reason that guys cannot have? What's that? Release that when? Bingo. So your ligaments get looser once a month. And so if you're playing soccer during that time frame, and that's why I went into orthopedics, so I don't have to talk about these things. But just know that that's one of the reasons why girls have their ACLs more and more. Think I'm joking? Look it up. So once again, felt and heard a pop. These people will come in and say, oh my gosh, man, I thought somebody shot me. This thing pops, and when it pops, sometimes even other people can hear it. It will swell up immediately because of the artery going through the ACL. So ACL sprain presentation, once again, large effusion, onset within usually first 4 hours. This is just a sprain. Feelings of giving way provided they're able to bear weight, loss of range of motion either in flexion or extension, because remember, whenever their knee is inside this water balloon, they tear their artery, it swells up. So imagine trying to make a water balloon out of a completely full water balloon. Well, there's no give to it, right? There's no twisting or anything. It's hard. That's why if you can't examine these people on the field or shortly afterwards, you're going to have to wait a day or two because they are not going to let you do anything, and their knee's going to be so swollen you can't do anything. ACL sprain, so Lockman's. This one to me is easier than the ACL, the anterior drawer. Have you guys seen somebody do these yet? Okay, so what's the one reason why a Lockman would be better, in my opinion, not textbook, but just in real world, than an anterior drawer? Because what can they do with an anterior drawer that they can't do with a Lockman? They can flex their hamstring. Right, so if you have me, Mr. Big Hairy Guy, coming in and you're 14 years old and you think you just tore your ACL, I say, hop up here real fast and I'm going to yank on your knee that you just hurt. You're going to go, no, I really don't like that idea. So what happens is when you pull on their ACL like this, so if I have somebody here and I'm trying to do an anterior drawer like this, if they flex their hamstring, it gives you that false sense of security, because remember the pes anterior and all that stuff that was attached to the front of the tibia? Well, the ACL prevents what? Anterior translation of the tibia, right? So if I'm doing something that pulls it back, I'm going to get a false negative. Does that make sense, kind of? So what I'll usually do, and once again, when Bannon and I do our assessment here in a second, it is because, and what I'll do is I'll even have them lay their leg over a little bit. I'll say, just let your leg fall off the side of the table. And as soon as you feel them relax, pull it. And once again, this is did we talk about the water skiing last time with the shoulder? Did we do that? Yeah. Yeah, so the water skiing, like, don't just lean on it. So, and the hard part is, and sometimes, I'll tell you what, like we used to do collegiate hockey and football and stuff, and I promise you, these linemen, and it's not sexist or whatever, girls, you're not going to get your hand around it like this, dude. I promise. I have to put my forearm behind them and pull like this. So I can show you guys a couple of adaptations that if you have smaller hands, you can still get a good exam. But nobody will get a good exam unless you get them to relax, and that's hard to do. Ask them their last name. Ask them how hot it is outside. But as soon as you feel them relaxed, don't go, okay, now hang on, I'm going to pull like this. You're just going to jerk it. If it's torn, it's torn. You're not going to make it worse by jerking on it. Just jerk it. I'll show you how to do that. The Lockman is flex at 20 to 30 degrees flexion with hip external rotation. The hip external rotation is you get them to relax. It's hard to engage their quadricep or hamstring if their hips externally rotated. Distal hand grasps the proximal tibia. Anterior translation is applied to the tibia while the femur is held fixed. So he's actually pushing this down and pulling this forward. Lockman is the most sensitive and specific test for ACL pathology because you can't flex your hamstring and give me a false negative. Anterior drawer. Okay, so let's go through this. If she says, I don't want you to do this, she flexes this, and all of this stuff pulls the tibia backwards, right? So he's going to go, man, that feels pretty good and tight to me. Well, no, she just flexed her hamstring. Anterior drawer flexed at 90 degrees, foot flat on the table, thenar eminence of both hands placed. Wow, they got really depth on this. But put your hands on their legs. You'll put your thumbs on their tibial eminence where your patellar tendon attaches. neutral position, and then you'll grade it. Now, usually the grading, you don't have to do this until you've been doing it a long time, but we can actually say, look, it pulled out a half, or it pulled out a 1, or it pulled out a 1.5. But once again, it's anything that you don't feel an endpoint, and I'll actually dictate. Because going back to a second ago, whenever I said test both sides for ligamentous laxity, you can be loose. You can have people you go, oh my gosh, I think they tore their ACL, then you do the other side. But if it stops at an abrupt stop, you can say, hey, it's got a palpable endpoint. And PCLs are even easier to feel. Grading test, anterior drawer, and Lockman's. 0 is negative, 1 is this. Once again, you're not going to get your ruler out. It's a feel thing. Grade 1 is a little bit, grade 2 is a lot, and grade 3. So this one is what we would call sloppy, a grade 2. Means that thing is just loose. You can pull it all day long. It's just going to keep coming. Really, the only thing that's going to stop it's their hamstrings and their PCL. And I don't know that I've ever seen a grade 3. ACL sprain workup, radiographs, once again, not show anything unless you get a lateral, and whenever they're putting their weight on it, oh, don't start yawning yet, I saw that. So, we're not even halfway done. So, whenever they're putting that stress on it for the lateral x-ray, remember, what does your ACL do? It keeps your tibia what? Back. So you may see a little bit of anterior translation on the tibia on the lateral radiograph. Tibial spine avulsion, this is always almost missed. On the AP radiograph, whenever you just look at it, everybody jumps to what they know. Once again, it goes back to the gorilla thing. I want you to, whenever I was at OU, and I forgot who was teaching us radiology, I think McNeil did a little bit. I still can't call him Dan. It's weird even after 17 years. He told us whenever you're looking at hands and feet to put the toes and the fingers up, and then you start at 1, and you just go down and down and down. So once again, even as something as minute as, or it's not even actually minute, I shouldn't say that, it's very important, but when you're looking at x-rays, I still want you to go through the same thing. I want you to follow all the curves around, because once again, if they have this big 5th metatarsal fracture, and they've got a tumor on their big toe, and you miss that, that's bad news. So always check everything. Tibial spine, where your ACL and your PCL attach, that's a big deal to miss, because if it's on an adolescent and you don't tie that back down soon, that's not going to be good for you at all. Rule out tibial plateau fracture, especially in traumatic cases. MRI, once again, gold standard, best seen on the sagittal MRI cuts. Okay, so here we go. Femur, tibia, patella, patellar tendon, or quad tendon, patellar tendon. Your ACL starts back here and it runs forward, right? Your PCL is that little bitty thing that's going like that. So this is your ACL. Now, can you see it there? Not really. You can see some of it, because remember, if it's going to take loose, if it's going to turn loose, it usually turns loose from the femur. Okay? So what you'll do, and you're not going to be reading this, that's why they pay radiologists. The only time I look at them is when the MRI doesn't line up with what the, or it's whenever the exam doesn't line up with what the MRI said. So once again, right like this, so the ACL should be going right like that, PCL comes down. You can see that disrupted right there. So either let's go with the femur, or it does mid substance right there. You can't see that definitive black line that goes there or there. Everybody got that? Okay. Treatment, aspiration of the hemarthrosis is clinical judgment. So once again, anytime you take something outside somebody's body and put something inside their body, there's a risk of infection right off the bat. I don't care how sterile you are. The reason that we do aspirations of hemarthrosis is for comfort and function. If I have somebody who we think tore their ACL, or whose leg is as big as a house, and if I sit them on the side of the table and they cannot let their leg fall to a 90-degree angle because it is so uncomfortable, I will consider aspirating it at that point. And even then, that comes with a lot of it, because I don't know if any of you have ever had your leg aspirated or your knee aspirated, but it hurts like hell. And so you remember, you don't want to be the bad guy all the time. So is it necessary to do it? No, it's strictly for comfort. Weight bearing is tolerated on crutches, knee immobilizer during ambulation, early range of motion, PT for restorative range of motion or severe fusion. Refer them to us. If you even think they did it, it's either one of two things. Put them in all that stuff, go get an MRI and send them to us, or just send them to us, we'll go get our own MRI. ACL reconstruction is no longer just for competitive athletes. No kidding, we did one on a 47-year-old lady not too long ago and did amazing. So age is kind of one of those things that we look at it as age is what's on the piece of paper, but how does the patient look? We also just did a total hip replacement on a 90-year-old the other day. People think, man, you're 90, you're eating applesauce, you're not doing anything. Leave your hip alone, right? Well, it's not true. This guy was actually still out cutting and chopping firewood with an axe at 90 years old. So his physiological age did not match his calendar age. So you can't just assume when you're walking in the room and you're looking at your piece of paper before you go in, because believe me, you will. You'll go, wow, this lady's 47, it doesn't really matter. Yeah, it does. This 47-year-old was still playing competitive indoor soccer. So it's not just for athletes. Counsel patients extensively on what if they choose to use non-operative treatment. Here's what I mean by that. Is so remember this, that I think it's 65% of all ACLs also have a meniscal injury, right? Because of the mechanism. Don't quote me on the 65, but it's more than 50. So if we think about it, if your femur and your tibia are supposed to do this with a normally functioning ACL, what happens with a torn ACL? It goes like this. So you can imagine and see how that shearing force could go ahead and tear a medial meniscus, a meniscus in general. So the counseling is, look, I understand that you're 50 and you don't want to have your ACL replaced. No doubt, I don't disagree with you. But if you leave it like that, we're going to have to get you in some kind of a derotational brace, because ACLs, remember, they also provide a rotational stability. And also, you could end up tearing your meniscus just because you have the MC or the ACL tear. And then also just, but we had an athletic trainer, no kidding, he had a torn ACL for 13 years and he could play golf and snow ski and do all this stuff. So it's all about how you kind of rehab yourself. But for the most of the people who want to cut and pivot and stop abruptly, you got to have your ACL. ACL tears generally considered to be surgical. Argument exists on the capacity of the ACL to heal due to the lock and clot formation, blah, blah, blah. They don't heal. I can't remember the last time we just watched somebody, unless it's a kid. It doesn't have a good vasculature. Remember I said whenever you tear that ligament or that artery, right? And impaired cell migration, all of this stuff. So you guys can look this up and read it, but I'm telling you right now, it's going to come down to, do I think you tore it? Did we get an MRI? Does it show that? And tell me about your quality of life. Right now, with your knee feeling unstable, sometimes people say, man, I feel fine. I'm going to go do my stuff. Great, go have a good life. They may come in and they say, look, I can't even go up and down stairs without this thing buckling on me. Okay, we got to do it. So just because the book says it doesn't mean to do it right now. You guys, for your boards, do what the book says. Reasons to reconstruct surgically, once again, return to stability for athletic participation, or maintain the articular cartilage. So I only touched on the meniscal injuries. Also remember what your femoral condyles and your tibial plateau are doing if that thing is translating more than it should, right? Okay, questions so far, everybody good? Okay, good. PCL injuries, PCL sprain, PCL provides 95% or more of the resistance force of the posterior tibial translation on the femur. More vertical alignment, so you remember when we saw it on the MRI, it goes more up and down than that diagonal ACL, therefore less rotational stability, and usually uninjured in rotational injuries. So all these people are coming out and pivoting on and all that stuff, we will usually get your meniscal tears and your ACL tears. That's why PCLs are so hard. Usually PCLs mean I got hit with something going straight frontwards, backwards. So like if you've ever seen a football player who was standing still and wasn't paying attention, and somebody comes and they just take him out at the knees and it just pushes it straight backwards. That'll tear your PCL. Or they hit the dashboard. That's another pretty common one. When you get hit head on by somebody, you slide forward, you hit your knees on the dashboard and it'll shove it backwards. Once again, same presentation as ACL, large effusion, usually within 4 hours, painful, limited weight bearing. Symptoms of instability, direct blow or contact injury as compared to many ACL injuries that are non-contact. Remember, 75% are not contact. Key is the differentiation prior to the exam is the mechanism of injury. So if they say, look, I was doing this deceleration thing, well, you know it's an ACL. And that's the other thing too, guys, is whenever you start hearing this stuff, when people start talking, you're automatically going to go, yeah, they got a meniscal tear, right? I mean, we'll go through the exam, but you have a meniscal tear. But it's very, very common. You know that old saying, common things happen commonly? You guys are going to sit here. I had a boss one time. My first job out of PA school was I worked in Las Vegas for a hand surgeon for a year. And he told me, once again, I think I told you this the other day, we only get MRIs to confirm what we already know, right? And then also, you should know what you're going to do with someone within about the first 5 minutes of them talking to you. You'll see, if any of you ever come do rotations with me, you'll get so tired of hearing me say the 5 hands, or the 5 things, and all this stuff, and you'll hear it. You'll hear people start to say, yeah, I was playing indoor soccer, and I was going to get a ball, and I twisted on a planted foot, and now every time I bend my knee back real far, it kind of pops, but once it pops, it feels better. What does that sound like? Don't say ACL. What What does it sound like? Meniscus tear, right? So, and you hear these stories over and over and over again. Now, you still need to do your exam, and you still need to get MRIs and all of those things, but you guys will pick up on this very, very fast. PCL exam, posterior drawer, same positioning as the anterior drawer, but obviously going backwards posteriorly. Done sequentially with the anterior drawer. Well, this is what I mean by that. So remember, you have a small amount of time for them to relax when they do that. So as soon as you see their leg drop off the table, pull it forwards and pull it backwards. It's a two-step thing. It's bang, bang like that. It's super, super fast. Because remember, the longer that you tell them, and I don't tell them I'm going to do it either, because then that's when they tense up. So you ask them, once again, their last name, what's it doing outside? You going on any vacations this summer? And as soon as you feel them relax, pull it and push it right there, okay? And I'll show you guys how to do that. If Sally hasn't already. Same grading based on laxity and endpoint. You may often see the sag. So what a sag is, you hold them up like this, and the one with the PCL, this will fall backwards. You'll see their tibial eminence or tuberosity fall backwards. Godfrey's, I don't really do that one that much, but once again, the biggest thing is to me it's a posterior drawer, and I'll do a sag sign if I'm confirming it. But to do this, you have to get them to relax, and once again, when you're hurting, it's hard to relax. MRI is a gold standard. Once again, you'll see this in orthopedics. MRIs, I mean, MRI places love me because, I mean, that's what we order, right? So PCL goes right here. It's not lax at all. It's not taut like the ACL is. And then you can see where it's not so much anymore. It'll get real thin and wispy. ACL treatment CACL treatment for acute treatment. Like I said, I think the last time, I think it's been 10 years since we fixed a PCL. Because I did it at my last job, and I've been at my current job 10 years. So that's how infrequent these are. A lot of times people don't need it, because usually people who tear their PCLs, remember, it's more of an injury type thing instead of a sports type thing usually. Young and involved, so once again, if their last one we fixed was actually a female basketball player, multi-ligament injury, so once again, if you've got more than one, we're probably going to fix them all. Chronic injury with symptomatic instability, 4 to 6 weeks to immobilize, and then follow up with therapy. Okay, everybody good on the ACL, PCL, and all this. Now this one's a little bit slower than the shoulder, but I don't care what you go into specialty, unless you're doing like pediatric oncology, you're going to need to know this, because this is the stuff that's going to walk in on the quick cares, the ERs, the primary cares. You guys have to, in fact, for primary care and quick cares, I mean, you should be able to thoroughly be able to call me and tell me what to do on a shoulder, back, hip, knee, and ankle. And wrist. You're going to see a ton of broken wrists all the time. LCL, least common of the four, mechanism of injury, is difficult to accomplish because, once again, think about it like this. If I'm standing here like this, it's very easy for Van to come over and karate chop me like that, right? There's really no protection other than me going like this. How easy is it for her to come kick me like this without me going, hey dude, stay over there, right? So it's very hard to have a varus stress on your knee. Injured by a varus load placed on the knee, impact on the medial aspect of the knee going outwards in a valgus stress. Once again, football running back presents, don't you like how they use football players all the time, they pick on us. Presents with a lateral knee pain and swelling, and states that he was running a ball, and while in mid-stride, well, now I'm exposed, right? Now it's easy for me to do or have somebody hit me like that, and that's when that'll happen. Presentation is exactly, so that's the cool thing about the ACL and the PCL and the MCL and the LCL. Actually, you just flip it. So one's a valgus stress, one's a varus stress, one's an anterior drawer, one's a posterior drawer. So once you get good at one, you're going to get good at the other because you're basically just doing the same thing on the other side. Effusion within hours of injury, lateral knee pain with palpation. Laxity with valgus stress, once again, at 0 and 30 degrees because they can still lock up their quad and give you a false positive. Ligament palpable with a figure of 4 position. That's one of those book things, but I don't really use that. Basically, if they have laxity, if they have tenderness over their LCL, laxity and a valgus stress at 0 and 30 degrees, I'm already worried. And the cool thing is the treatment's exactly the same thing as an MCL. MRI. You're going to make them be weight bearing as tolerated, hinged knee brace for grades 2 to 3, but once again, if they have laxity and they don't feel comfortable and they feel it's going to give out on them, that's whenever I put them at 30 degrees, just like the MCL. It's literally the same treatment. Surgery on these will be by far more common than the MCLs because MCLs don't need surgery the vast majority of the time, but they're so few and far between that you won't be doing that many LCL surgeries because nobody really hurts them that much. All right, everybody cool on the 4 ligaments, right? One goes forwards, one goes backwards, one goes inside, one goes outside. Once you get that down, you're good to go. Meniscal injuries. Meniscus, semilunar cartilages, fibrinogenous cartilage, discs that aid in shock absorption, load of distribution on the knee and during motion. So, you've got your medial and your lateral. So this is actually an arthroscopy picture. There's your medial, or I don't know which one it is, but femoral condyle, tibial plateau, and there's your meniscus. And this part right here is actually super, super thin. Articulate with the tibia and concave in shape, thinning to a free edge on the medial aspect. Usually occurs with a combination of a load and shearing force. So I put my foot down and then I'm twisting it. So think of like grinding pepper. You're just trying to twist on it during a rotational activity, especially true in the young and healthy patient. So once again, these are your indoor soccer players. Anybody who cuts and pivots, tennis players, racquetball players, anything that and especially indoor soccer. Because in grass, when you're playing on outdoor fields, the cleats usually don't have as much grip. But whenever you put somebody in indoor soccer, your foot ain't moving, usually. Aging meniscal tears are in the aging population are often atraumatic. These guys, I swear to God, I saw somebody tear one tying their shoe. They simply bent over to tie their shoe and they lost their balance and then they went like that to catch themselves for their meniscus. You can do it stepping off of a curb. You can do however you want to do it. Generally simply is rising from a seated position or stooping over to reach something on a low shelf, once again tying their shoe. They may also be chronic in nature. Zones of the meniscus. So red is the outer third of the meniscus. Plentiful blood supply from the capsular margin of the meniscus. Red-white's the middle third, diminished vascular, and then white is completely avascular. That's why a lot of times whenever people have meniscal tears, we have to do surgery on them. That's why meniscal surgery is our bread and butter. If we go a week without doing a meniscal surgery, I'll be shocked because there's so many that are torn, and very few people, unless they're young, tear them out here. It's usually over here in this avascular part. And you have to remember that the meniscal, they call them hoop fibers. So if you look at your medial and lateral meniscus like a hoop like this, the fibers run around in a circle, almost like the annulus on a disc in your back, right? So that's why if you tear it in the, depending upon which one you tear it in, even if we sew it together, if it's a tear that goes like this through the meniscus, well now you're sewing together hair. You're sewing together fibers, right? So then as soon as you put the stress on it, it's going to pull it out. It's only the tears that run in contention or in parallel with those fibers of the meniscus that you can even sew back together. It's this is what determines on an MRI whether we do surgery on somebody or not, as well as age. Importance of these zones, location of the tear aids in dictating treatment course, may be commented by a radiologist, but not usually. They usually won't say, hey, this is a red, a red, white, or a white. They'll usually just say this is a, I'm sure you guys have learned the different types, but there's horizontal parabeak, radial tear, different things like that. So once again, what it comes down to is it's fine and dandy what they say, but you're still going to have the same conversation with your patient. You have a meniscal tear. You having mechanical symptoms? Yeah, man, I can't even do what I'm doing. I'm not able to do my job. This is really uncomfortable. It's affecting my lifestyle. And then as soon as they say that, we talk about surgery. Vast majority of symptomatic tears occur within the inner two-thirds where there's little to no capacity to heal. So these are the people that we are doing surgery on. This one can arguably be had by someone who's younger and heal it without surgery. Mechanical symptoms described are, once again, the most telling. Popping, locking, clicking, catching. One-sided knee pain, all medialized or all lateralized. Now, usually this is not common with things that you'll see otherwise. If you tear your MCL, it's not going to hurt on the outside, right? If you tear your ACL or PCL, it's kind of vague, so it's in the middle, but it won't be right side or medial or lateral. Same thing with arthritis. People don't come in with arthritis complaining about the left side of their knee hurting or their medial or lateral. They'll say, it's kind of like a generalized toothache all over my head or all over my knee. And that's kind of, this is pinpoint. Knee effusion that came on slowly over the course of 12 to 24 hours. Once again, a twisting injury. Impingement of the torn meniscus usually generates pain. That's why when you do your McMurray's and your Apley test, that causes that. Palpate the joint line at 9 degrees of flexion, medial or lateral joint line pain. Now remember, joint line pain can also be consistent with arthritis too, so that's just a positive that you want to determine or dictate. Provocative test, Apley's and McMurray's, you guys know how to do those, right? Right. Have you guys done those yet? So what's that? Not Apley's. Apley's is kind of, once again, if I do a McMurray's on somebody and they have the story that goes with it, I usually won't do an Apley's, but an Apley's is the same thing as a McMurray's, but you have them flip over on their belly, and now you're basically, you have them bend their knee to a 9 degrees of flexion, and you push down into the table while you're twisting it. So you're basically taking their tibia, and so if, I'll show you, but It's unnecessary in my opinion, because once again, if you get a positive McMurray's, are you going to go, well, I didn't get an Apley's, it must not be a meniscal tear? No, it's a positive McMurray's still. I think when you read in your books, it'll say to palpate the joint line and do the external and internal rotation, and that you should feel a pop underneath your finger. I think if you truly read like a McMurray's test, that doesn't happen. I can't remember the last time I felt something pop whenever I did a McMurray's test. Deep squat or duck walk, once again, if you're doing that, it's just kind of being me. Athlete's compression test, athlete's distraction, which means if you pull up on their foot while you're internal and external rotating it, it won't hurt as bad because you're not pushing down the meniscus. McMurray's, this is it. This is the gold standard if you ask me, because you can do this with them laying down, you can do that with them sitting down, you can do that with them in a wheelchair, you can do a McMurray's test wherever and wherever. You find a position that I can't do a McMurray's test on you, and I'll buy you some ice cream. Combines with Apley's compression for varus and valgus stress, terminal flexion and extension. So this is an Apley's test. So if you can imagine your meniscus are on the tibia right here, and they're running anterior to posterior. So what he's doing is he's shoving their leg down under their femoral condyles, and then he's twisting it. So he's basically trying to trap it to reproduce the symptoms. So this is obviously Apley's. This is McMurray's, and I'll show you guys how to do that. So whenever you do McMurray's or Apley's, just remember, if your toe is pointed out, you're testing for the medial meniscus. If your toe is pointed in, you're testing for the lateral meniscus. So whichever way your toe's pointed, you would test for the other. So whenever I do the exam, if I turn their foot out and gently bring them down into extension, and they say, oh, I feel that on the inside, that's a positive medial McMurray's test. Everybody with me so far? Everybody good? Okay. Radiographs, weight bearing, AP, and lateral. The minimum at our view, or at our clinic, everybody gets 3 views of the knee. You get an, unless you're adolescent, you get an AP, a lateral, and a 30-degree bent view. So what we do is we have them flex to about 30 degrees, and we shoot a P to A view, because that will give you a better view of truly how bad their arthritis is. Specialty, make them bilateral, add a notch view, once again 30 degrees. MRI, once again, gold standard, gold standard, gold standard. So remember, and I just took and I know you guys aren't thinking boards yet, but I just took a review course called CME for Life. Has anybody ever heard of that guy? A guy named John who's bald and is like a cartoon character in a live person's body. Have you seen him? Like, he's all over the place, and he was great, and he makes things easy to learn and stuff like that. But remember, whenever you're taking your boards and things like that, the PAs, and especially now with this new alternative pathway that I signed up for because I don't want to have to worry about all the other stuff, is they want you to do the least invasive things first, right? So before you start sticking holes in people's knees and stuff like that, the only reason to do that's what? Infection, right? Am I worried about it infected or not? So before you're invasive, is there something that's an answer to the question that is not invasive? So remember that. That was one of the things he beat into our heads. So once again, MRI is the gold standard, second only to a diagnostic arthroscopy, which means it's only second to us literally putting our eyeball on the meniscal tear. Meniscal tears, well, when you look at meniscus, there are these little triangles right there, right? So now look at that one and look at that one. Does anybody see a difference? The fluid in between, right? So see, there's your meniscus, there's your meniscus, there's your meniscus, there's your meniscus, and you can see fluid in that one, right? And remember, your T1 and your T2 weighted images are going to give one's going to be the bone's white, one's going to be darker. So, and this is that tibial eminence. Now this doesn't show anything other than, I believe on this one, they're showing you what a flipped meniscus could do, because you can actually have something called a bucket handle. See this right here? So back in the old days, they used to have these metal buckets, and the bucket handles would literally lay down on the top of the bucket to make it flush, so you couldn't almost see it. Well, what happens is if you have this, one of the main reasons for a locked knee, the only thing that will truly lock a knee, and they'll come in like this. They'll come in and go, dude, I'm not straightening it or moving it. This is it. Don't touch it. That's what happened is they had this bucket handle tear, and imagine this whole portion right here flipping over on the inside. Well, it'll kill them, right? And so, did I tell you guys the trick about a shoulder dislocation filling with 20 cc's of lidocaine? You can do the same thing in a knee, and it will distract it, and it will flip it back over. That's pretty rare. I haven't seen that in a long time. Conservative treatment patient, well tolerated with symptoms, no deficit in passive range of motion. You know, really, once again, we have people who, for one reason or another, can't have surgery, bad heart, bad lungs, grandma's sick. I mean, there's always a reason for it, but you can truly have a meniscal tear and finish out a basketball season as long as the symptoms dictate it. So just remember that no matter what's wrong with somebody, if they can do what they're doing without the equivalent of limping, unless it's a bad fracture, unless it's any kind of fracture, they can still kind of do it as long as their knee will let them. So do we let basketball players play basketball seasons on torn meniscus? Absolutely, until they start limping, and then they're done. And that's my kind of relationship with them. I'll say, I'll be fair with you, but you got to be honest with me. You want to keep playing, let's keep playing, but the second it starts hurting, or same thing with shoulders, the first time it comes out again, we're done. Includes RICE, anti-inflammatories, intraarticular steroid injections, which remember, none of this will cure that meniscal tear. Nothing will cure the meniscal tear. Not leaving it alone will do nothing other than it's still going to be there. It just may not be painful, except for those red zones on teenagers, and those can actually heal. Bracing not effective other than for effusion control. Because remember, your meniscus are aggravated by what? A downward pressure with a weight bearing and a pivoting, right? So you put me in whatever kind of knee brace you can find on Amazon or in our office, and you still can't keep me from putting my weight on my leg and twisting. Flexion extension braces, neoprene sleeves, those Tommy Copper things at Walgreens, it's all going to happen, right? So there's no brace that you can put somebody in, because they'll ask you, they'll say, I've got a torn meniscus, I need a brace, and I'll say, that's fine, it's going to help with swelling, but it's not going to do a thing else for you. Surgical bereavement versus repair symptoms that affect the activities of daily living or repair athletic activity. Once again, just because you have one of these doesn't mean you have to have surgery. Bucket handle, you're probably headed towards surgery. Large tear in a repairable zone of the meniscus, once again, if it's in that red zone, we can repair it if it's in a certain type of tear. Partial meniscectomy, meniscal repair, or trephination, which I believe is to take out the whole thing, but they haven't really done that in a long time. So once again, does everybody understand what I'm kind of saying about the fibers of the meniscus and when we can repair them and when we can't? So if you imagine your meniscus, and let's pretend like this is anterior and posterior, so the fibers run anterior and posterior. So obviously if we have a radial tear or a horizontal tear, and we try to sew this piece to this piece, those fibers, it's just going to pull through. So the only way that works, so anterior, posterior again, so if the tear runs anterior to posterior, well now we can sew front to back, right? So we're clinching them together. That's the difference on what you can't fix and can fix. And a lot of times what we'll do is on our younger people who would be a candidate for a meniscal repair, is we even tell them prior to surgery, look, we're going to go and take a look. If we can fix it, we can. If not, we're going to trim it out, because trimming it out is still better than not, or leaving it in there torn, if that makes sense. Because also remember that your meniscus live between your upper and lower leg bones, right? They live right on the articular cartilage. So if you have this meniscal tear and they're playing bongo drums on your articular cartilage, what's it going to do? It's going to soften it, it's going to fray it, and you can develop premature osteoarthritis. So when people get this theory in their head of, if you go take my meniscus out, I won't have as much shock absorber, and then therefore it's going to be worse for me for the rest of my life. No, it's actually worse to leave it in there, because I can set you up for premature osteoarthritis. And whenever I was saying that about don't just rush them all to surgery, anybody who's like 18 and under, we have them do therapy first for about a month on a meniscal tear, because sometimes, and a lot of times, if they are going to heal it in that red zone, then that would be a way of knowing it. And if they come back after therapy and go, nope, nothing got better, sorry, then, well, we tried, but we're still going to have to take you to surgery. And I always tell people this too, a meniscal tear is, if you got to choose one thing, one kind of surgery to have in orthopedics, this is it. How many people have had a meniscectomy before, a knee scope? Just really, just one? That's pretty impressive. You guys are healthy. But if somebody puts a gun to my head and says, pick a surgery that you do to somebody else, what's it going to be? I'm doing a knee scope 1,000% of the time, because it's in and out. You're doing whatever you want to do roughly in about a month. Now, that's the other reason that we educate our patients of an age on the meniscal repairs, because if we do a meniscal repair on you, now you're not walking on it for 6 weeks. You're on crutches for 6 weeks. Now you're not returning to sports for 4 months instead of 1 month. So there is a big difference there. And it's good to educate them there instead of later on. Okay, tibial plateau fractures. This one is a bad fracture. It just doesn't look as bad. This one, you don't have to go through radiology to see that something is not right. This one actually, see how easy that tibial eminence is not to see? See that little one right there? That right there, and then it comes down and goes out. Same thing here, they got their fibular head. What nerve do you have to worry about if you have a fractured fibular head? So you're going to test what? What's dorsiflexion of the ankle, and document always sensation where? No, first and second toes. the web space between their first and second toes. Every single person that I see with a proximal fibula, and these are super rare. I've seen one probably in the last 3 or 4 years, but because usually these go to OU trauma. These don't make it to Olson Orthopedics because we don't take call anywhere. But the thing about it is that if anybody has any kind of lateral knee, I don't care if you think they've torn their LCL, document they don't have foot drop and they have full resistance against ankle dorsiflexion and complete sensation between the first and second toes. If you don't document that and you miss a perineal injury, not fun for you. Just give them your car keys. So once again, tibial plateau, tibial plateau. Fractures of the tibial plateau and condyles just below the knee joint line, generally above or including the tibial tubercle. Location 60% are lateral, 15% medial, 25% bicondylar. If you guys haven't looked up this yet, this Willis textbook of orthopedics, that's one of my bookmarks on my computer. It's got this skeleton that's in this weird shape, and you can just literally go click on their wrist, and it'll bring up everything you want to know about a wrist. You can type it in. There's a wealth of information on there. It's kind of like a PubMed for just orthopedics type deals. But check that out, definitely. So once again, you can see the fracture there, see the fracture there, see how it comes out through there. But if you didn't see this big gap here and this big gap there, that may not be so easy to see at first, right? Rule out compartment syndrome. Brad just talked about that, so you guys are pretty fresh on that. Evaluate ligamentous injury. So once again, how much do you think that dude's going to let me move his knee? Not, right? Okay. So you got to do what you can, though. Perineal nerve function, high incidence of proximal fibular fracture and association. Although proximal fibular fractures are very, very uncommon. APN lateral views at minimum, oblique in comparison to the contralateral side may aid. CT of the intraarticular depression or comminution with 3D reconstructions if possible. And I'll show you what that means, and these are huge. So you can look at that and just go, well, I can kind of see that, and I can kind of see that. Are those pieces forward? Are they backward? How much is it depressed? What are we looking at here? Now, when you do these CT coronal, or these CT sagittal reformations, this is nice. This is awesome because you can just sit there and spin it and look, and you can even plan on exactly how you're going to put Humpty Dumpty back together again. Because it looks like this in real life. You open it up and you're like, oh crap, this is terrible. So this one would obviously get a plate going across. This one needed a whole bunch, and you can actually kind of see the screws, which is kind of cool after their surgery. So on the medial femoral condyle, because what we care about most on the, medial tibial plateau is depression, right? So you can accept a lot more on the lateral side than you can on the medial side. The medial side, I believe it's 3 to 5 millimeters of depression. Anything more than that, surgery. On the lateral side, you can actually go up to, if my memory serves me, 10 millimeters of depression. You may check that out just to quote or fact check me on that, but because like I said, we don't do that much trauma like that. But you can accept more laterally than you can accept medially. Non-operative, non-displaced, or minimally displaced with a subtle knee exam, or stable knee on examination, which means you look at the fracture, it's not that displaced, and all of their ligaments from the best of your ability is to discern whether they're intact or not or good. Then you put them in an immobilizer, non-weight bearing, refer them to us, or other range of motion, because the hard part of orthopedics, one of the most difficult parts of my job, is to keep a knee moving so it doesn't get stiff without moving the fracture. Because either way, you're kind of hosed. If you move them too fast, the fracture moves. Well, you let me move too fast. You don't move me too fast, my fracture looks amazing, but now my knee's stiff and I have to do therapy for a long time. So this one, there's a fine line of keeping it moving enough and too much, or not enough. Operative, majority of, obviously from the x-rays I've showed you, those all got surgery. Displaced wedge fracture, condylar widening, depression of the articular surface, that's the biggest one that we go off of, or just gross comminution like that other, the one on the right was. Preoperative planning, consultation with surgeon on call, all of that stuff. That's another thing, just real quickly, if you guys end up working in the emergency room or whatnot, I know that for bookwork and for didactic reasons, they like for you to use names like Collies and Smiths and Bartons and Weber A and Weber B and Salter Harris and all that stuff. We don't like that. I want you to tell me where the fracture is. Is it dorsal or volar? Is it translated? Is it comminuted? Is it intraarticular? Is it extraarticular? Is it open or is it closed, right? So whenever people call me, back when we used to take call in the middle of the night, and then because how do I know if they know what a Smith's fracture is? Because everybody gets Smiths and Collies mixed up, right? All the time. So how would I even know what they're talking about, right? So just as a good practice, once you get done with school and once you pass your test and once you put down everything on the exam like you're supposed to, when you talk to somebody, especially if they're in orthopedics, make sure you know what you're talking about, and you can never go wrong by just describing the fracture. This is what I see. I see a distal radius with volar angulation, no comminution, it's not intraarticular. I know what that means. If you told me I see a Smith's fracture, I'll go, oh, what was Smith's again? Okay, cool. We'll just put him in a splint and I'll see him later. So just as from one person who's been doing this a long time to people who haven't been doing it, just describe it. You can't go wrong if you just describe it. Especially if you get somebody and you wake an orthopedist up in the middle of the night and you're wrong, that's a bad deal. Majority due to direct trauma. So patellar fractures. Everybody cool on tibial plateau fractures? Once again, pretty rare, but we don't do a lot of trauma. Majority of these are due to direct trauma in the patella, either from a fall or from a blow of any object. Baseball bats and baseballs, we get a lot of those. Can occur with forceful or dashboard. You can get a lot of these from dashboard injuries too. Forceful contraction of the quadricep muscle is usually resulting in a avulsion fracture of the superior pole of the patella. So what they're basically saying is, look, you're either going to get hit with something, they're going to fall on it, or if for some reason I was going to kick something and my leg stopped all of a sudden and something pushed it backwards, like those, you see the football players when they're jumping over for the touchdown and then somebody grabs their legs and drags them backwards. If their quadriceps are strong enough, they can actually pull off the top part of their patella. Severe anterior knee pain, knee held in full extension. They do not want to flex this. Why? Because when they flex it, their patellar tendon is going to pull the bottom half of the patella one way. Their quadriceps tendon is going to pull it the other way. So you're basically going to be splitting their kneecap in half every time you bend your knee. So when you walk in the room, you're going to say, hey, can I take a look at your knee? And they'll go, here it is, but you're not touching it. Don't move it, don't touch it, don't breathe on it. It hurts. These things are very uncomfortable. Once again, severe anterior knee pain. It's not toenail, it's two-no range of motion present. Large joint effusion, which means what? Swelling inside or outside the knee? Inside the knee. And potentially lower leg edema. Remember, when something breaks, it bleeds. When something bleeds, gravity is going to pull it towards gravity, so it's going to go down. We've done total knees on people and we'll bruise their big toe. So gravity pulls all that blood down, so it's not uncommon to have a knee injury and have lower leg edema. Generally unable to wear weight unless they're in full extension. Whenever you stand in full extension, even with a fractured patella, there's no stress on it. So a lot of times you'll see them coming in from the emergency room with those goofy foam immobilizers that have the big white straps across them. They're using navy blue or whatnot. So they can usually come in putting a little bit of weight on that. We call it toe touch weight bearing. They can hold their toe on the ground just for some stability, but as soon as you ask them to bear weight on it, they can't usually do it. 3 views of radiographs, the AP, the lateral, and the oblique comparison is very helpful. A sunrise view, if at all possible. Now here's what does everybody know what a sunrise view is? Where you're looking over the femoral condyles and it's like the little birds are chirping and all that. But you got to remember, what did I say the hardest thing to get somebody with a patella fracture to do is? Bend your knee. Guess how you get that view? You bend your knee. So once again, taking little Billy with a broken kneecap and saying, hey, I know your knee hurts. We're just going to kind of squeeze your knee up a little bit. It didn't happen. CAT scan, this is not usually necessary. I can't remember the last time that we fixed it, and we fixed 2 kneecaps last week, and I can't remember the last time we ordered a CAT scan for that. That's only if something seriously screwed up. MRI can be helpful if no CT available, and the patient can remain still. Once again, they're hurting, right? All right, so direct trauma, more comminution, articular cartilage damage. That's what we care about. And it's funny, when we fix these people's knees, when you look at the lateral radiograph, the articular surface is pristine. It is perfect. It is lined up. It is all there. And you may have a little bit of a gap in the front. That's all going to fill in. What we care about is the articular surface, because that's what's touching your femur, right? So if that's not looking good, but the front side is, who cares what the front side looks? You got to get that articular cartilage down. So that's what they're talking about. Indirect trauma, less comminution, transverse type fractures usually associated here. So it is very rare to have a superior to inferior fracture. It's very, very common to have transverse fractures. One part goes one way, one part goes the other. Displacement of the patellar fractures, any incongruency of the articular surface less than or greater than 2 millimeters. 2 millimeters is tiny. You know what a millimeter is on a ruler, right? That is super, super tiny. So that's saying it better be darn near perfect or we're going to have to fix them. Greater than 3 millimeters of separation of fragments, you're fixing them. This is a sunrise view. Now you can see on this one, you can imagine if we just took a lateral, right, that went straight across, you're not going to see that, right? You won't even see that on an AP view. You'll see that on a sunrise view. So this is someone that usually, that's probably about a week or two later after they've gotten a little bit more comfortable. Their soft tissues have kind of calmed down. This is a transverse fracture, the inferior pole of the patella. Because remember, like I said, some of it's going up, some of it's coming down, depending on is which half's going to be bigger and is it going to be displaced. Obviously, this is the patellar tendon tore the bottom part of his inferior pole of his patella off. This is a comminuted one, so that was probably due to direct blunt. So that's kind of the best way to think about it. Usually if it's a resisted extension or something, you're usually going to have these kind of transverse fractures. If you get hit with something, it's probably going to be more of a comminuted, like if you got hit with a baseball bat or something like that. Non-operative, non-displaced, extension mechanisms intact. That's kind of what's cool about this thing is even if they have that, you can still do a straight leg raise test on them because you're not pulling the parts apart. You're not increasing the distraction of it with flexion of the knee. Does that make sense? So if your leg's straight, and you used to have, does everybody know what a straight leg raise like a quad set type deal is? So you can have them still raise their leg up. Now whether they do it or not or want to do it, we'll see. But that you can still test whether they can do it or not. If the extensor mechanism's intact, you're good to go. Because and the reasoning on this as well is, what happens if it's a non-displaced fracture and their extensor mechanism's not intact? What are you worried about then? The soft tissues, right? Well, is their quadricep tendon okay? Is their patellar tendon okay? So now you got to go get an MRI. Aspirate tense hemarthrosis. Once again, the only time that I recommend aspirating someone's knee, not only because of pain, but also because of sterility. And also, you got to remember, if you take that blood out of there, I'll bet you $5 it's back before the next time they see you. It's just going to fill right back up. So they went through all that pain, increased their risk of infection, and they'll usually call me back that next morning and go, dude, it came right back. So I only do this once again, in my opinion, this isn't a book answer, this is a real world answer, unless they can literally let their leg hang at a 90-degree angle off the side of the table and they are miserable. That's the only time I drain them, and it's very, very rare. Knee immobilizer brace for 4 to 6 weeks, slow progressive range of motion with physical therapy after 4 to 6 weeks. I tell every single one of our patients the average fracture takes 6 to 8 weeks to heal, and it usually takes another month to get your strength, range of motion, and confidence back. So anytime somebody breaks something, it's a 3-month answer. 6 to 8 weeks for the bone to heal, another month for you to get your confidence back in that fracture. And you'll be shocked at how true that is. You'll see it. Quadricep strengthening, of course, on something like this. So what we do is, this knee immobilizer, we don't do this. We do that same flexion extension brace I talked about, and for the first 2 weeks we go 0 to 30 degrees, so that way they can still move it a lot, because if you've ever tried to walk with a straight leg like a pirate, it's ridiculously hard. You either have to swing your leg around like this, or you have to use crutches and you kind of have to hike your hip up, which can cause your back and your hip to start hurting. So we'll give them a little bit of range of motion just so they can get in and out of the car, because if not, it's miserable. And remember, the more happy you make your patients, the more likely they are to come back, right? So we'll do 0 to 30 for the first 2 weeks, 0 to 60, 60 for the second 2 weeks, 0 to 90 for the third 2 weeks, and 0 to open for the last 2 weeks. And by that time, they're just coming in, looking good, walking on it, stuff like that, when you start therapy. Don't send people to therapy too soon on a fracture. If you send it to them before the first 6 to 8 weeks, you can actually, because you may, does anybody have friends who are therapists or family members or have been to physical therapy? What do you do when you walk in the door, right? They're like, hey, we're hungry wolves, let's get after this dude. You're going to get range of motion before you go home tonight. I don't want you to do that on a fracture. You've got to let the fracture heal. Remember that if a fracture is going to move, it's usually going to do so within the first 3 weeks. So we see all of our fractures at 1 week, 2 weeks, 3 weeks, and 6 weeks on everybody. Because if they come back to our office on the 3rd week and their fracture hasn't shifted yet, statistically it's not impossible, but it's less likely to do so. And then, so usually if it looks good at 3 weeks, I'll let them go another 3 weeks, come back and see me, check their range of motion, loss of range of motion. Now we're 6 to 8 weeks into it, I'm going to let you go to therapy. Operative candidates, obviously extension mechanism is disrupted anyway, you're fixing it. Displacement of a transverse fracture, which is what we saw on that guy. He's getting surgery, that will not get surgery. Because once again, look at what we're looking at. This is the articular surface. That's fine. That's beautiful. We all hope that our knees look like that, except for the large amount of arthritis. But that's what you want on a knee fracture. Displacement, comminution, articular step-off, once again, is the only thing that matters for the most part. Compromised skin overlying the patella due to trauma. So once again, if it's open, you're worried about infection, osteomyelitis. Dislocations of the kneecap. So this is a kind of funny story about my first dislocation. So my first job back in Oklahoma after we came back from Las Vegas was for the Luther Lions. Does anybody know where Luther is? Way out in the middle of nowhere? Yeah, got one taker out there. Well, Luther Lions, I love those guys, but it is bare minimum out there. Like the ambulance is older than I am. They kick the ball for field goals into the cornfields, and all these little kids go like running through it. So I was out there, and I had my athletic trainer bag. I'd read all my athletic training books, because athletic training and orthopedics are two different things. They're somewhat synonymous, but there's a lot of tricks that those guys learn that we don't get to learn in school. So they said, okay, so the major things that happen are nosebleeds. And what's the best thing for a nosebleed? Tampons. Who said tampons? So I had 65 tampons shoved in my, it was cold, so I had 65 tampons shoved in this pocket. I forgot what I had on this side. I think I had my gloves, my rubber gloves on this side, or my latex gloves on this side. I mean, I looked like I was going into war with orthopedics, basically. And so this kid dislocates his kneecap like that. And I run out there, well, I forgot to zip my pocket. So as I'm running out there on the 50-yard line, I've got a trail of tampons. I mean, no matter how good of a salesman you are, try explaining that to 2 football teams, 3 refs, and everybody on the sideline. So I was like, no back. So needless to say, you don't need that many tampons. You may need like 1 or 2, because nosebleeds aren't that common. So anyway, but yeah, so that was my first ever anterior dislocation, or kneecap dislocation. And people, whenever they see their kneecap on the side of their leg, freak out. It is not normal. It's just like an anterior shoulder dislocation. Your body goes, hey, this isn't supposed to be happening like this. You better do something to get this back in. So does anybody know how to get this better? This one's a hard picture because he's already in extension, but does anybody know if somebody's laying on the ground with a lateral patellar displacement, how do you get it back in? No, never push it. Bad answer. What else? Straighten it. That's all you got to do. So what I do is this. You tap on it, make sure it's not broken right. I mean, they're going to be freaking out, so you might as well tap on it. And then as soon as you realize it's not broken, you gently, and you have to talk them into it. That was actually a good answer, but just not the right one I wanted to hear. So what you do is you'll gently, while you're talking to them, talking about their mom's best ice cream that she makes, and whatever you can do to get their mind off of it, gently extend it, and as soon as you get it up over the condyles, it'll go right back in, and they will love you. Throw an immobilizer, they'll get an MRI. So, because you cannot, and the reason I say that is, and I don't want you to do it like that is because if you're taking that very, very strong mechanism, remember, quadriceps, quad tendon, patella, patellar tendon, tibia right here, so this is like a big crane right here, right? This is a high hill to climb, and if they are already worried and you're sitting on the ground trying to shove it back over their lateral femoral condyle, not only can you do damage to their patellar cartilage, their lateral femoral cartilage, but also just their whole extensor mechanism. But if you will just gently straighten out their knee after you've determined that there's no fracture, that's the best way to get it back in. Refers to the tibial or femoral articulation, not the patellofemoral. This is a limb. Oh, this is a knee dislocation. I'm sorry. This is just dislocations about the knee. So this is a knee dislocation. This is the whole knee. Refers to a tibial femoral articular dislocation, not patellofemoral. Life-threatening injury. Time is of the essence, laceration of the popliteal artery and vein. This is a big, humongous deal. I've seen 2 of these in my 17 years of orthopedics. One of them was a lady who her boyfriend in Midwest decided to steal her car. So she jumped up on the hood, like they do on the action movies, and he was swerving like this, and she was doing the windshield wiper on his hood, and he finally threw her off, and she dislocated her knee. This is a big deal. And so you will have a lot of people who walk into your office and go, hey, I dislocated my knee. And I'm like, no, you didn't. And they'll say, no. My doctor said I dislocated my knee. And 99 times out of 100, they're talking about their kneecap, not their knee. That's why you always want to document that their knee is not dislocated, because this is a big deal. These things will not ever see me until they're out of the hospital, or unless you're taking trauma call. Once again, laceration of the popliteal artery and or vein, a big deal. You can lose the bottom half of your leg if you don't identify this and start getting them worked out quickly. Multi-ligament injury, once again, that girl had torn her ACL, PCL, and MCL. Often both ACL and PCL, and then one of these. So it's usually one of those and then both of these. Luckily there isn't one, and these aren't common. So once again, 2 in 17 years, but you do not want to miss that. You know what it looks like? That. Now imagine her popliteal artery and vein and nerve and all that stuff around down here. So how do you think that's going to go? Oh, it kind of can't do that. So that's a big deal. So what's the one thing that you would want to document on this patient? Neurovascular status, right? So you got to show everything is still okay. You can see their deep thought going, oh my God, what's that? See their arm right here, and there's their shoulder, and there's their head. They're like doing like this. Patellar subluxation dislocation. Once again, we kind of went through this traumatic subluxation or dislocation of the patella. In order for the dislocation, one of the stabilizing structures must fail. This is your gold answer, medial patellofemoral ligament. So the way I describe it to our patients is, so they'll understand, is once again my beautiful analogies, is I say this is like a crane. You heard me say it earlier. So this is the big motor, and you've got the cable that goes up over your kneecap and then down. So when the motor pulls, it goes like this. This is a big, strong mechanism in order to keep your kneecap going up and down. It is very, very strong. Your quads are crazy strong. So the hard part is, when God made us, He put this little bitty thing that's about the width of my thumb that kind of just hangs on the patella and goes, man, I hope nothing happens, right? So it's this guy versus this guy, and they tear it almost every single time. So what happens is, when you get your MRI, it'll show a bone bruise of the, oh, come on, think about physics. It'll show a bone bruise of the kneecap going out, right? So the lateral aspect of the patella, because it had to hit the bump to go over it, and it also had to bruise your lateral femoral condyle, so you'll have a contusion of your patella, your lateral femoral condyle, and a rupture of the medial patellar retinaculum. This is almost always what they'll see. And some people use these synonymously, but it's this medial patellar retinaculum. Chondral surfaces, once again, the bone bruises. Most common in adolescent population and more common in females than males. Why?
Because the
Yes,
yeah.
that. And also, usually, what'd you say? You're doing this. What's this?
the fossa, right? They're the
Trochlear.
yeah.
Yeah, so a lot of females have what they call trochlear dysplasia. That means that the valley that the kneecap lives in on the femur is not as deep. So if you've ever stood in a drainage ditch or any kind of a ditch, like whenever they used to ride the skateboards and the bikes on them, the higher the walls are, the harder it's going to be for you to get out. The lower the walls are, the easier it is going to be for you to slide out. So if that trochlea on the end of your femur is not as deep, if it's more shallow, your kneecap can go that way a lot easier. They will always go laterally, unless somebody literally gets hit with a baseball bat and shoves it medially. Because remember, your medial femoral condyle is bigger than your lateral femoral condyle. So if somebody says, I dislocated my kneecap medially, I'll actually start taking bets with them on what their MRI is going to say. And I haven't seen one yet. That's a safe bet to take, unless in trauma. Anatomic variants predispose a certain population. Once again, hypoplastic femoral trochlea, patella alta. Do you guys know what that is? Patella alta and patella baja. Patella alta means that whenever you take a look at their lateral x-ray of their kneecap sits higher. So remember that whenever you look at a femur like this, right? So this is my femur coming up, and here's my hip. Whenever you look at a femur, the higher up your femur you go, the less deep the trochlea is. So if I have a kneecap that's supposed to be down here, it's going to be really hard to do this, right? So what if my kneecap sits up like this? That's kind of easy. So they will either have one of the two or both. Patella baja you can tell off of an x-ray because you're going to take a picture of their what? Other side. Right? Is that kneecap up? Oh, that looks funny to me. Take one of their other side. And sometimes they'll have both. But so if they have a patella alta, which is too high, patella baja, which is it's too low, and a hypoplastic femoral trochlea, which you can only tell on an MRI, that sets them up for that. Lateralization of the tibial tubercle. So once again, if you're, this gets kind of super nerdy, but I'm here. When your patellar goes to your patellar tendon, the patellar tendon goes to your tibial tubercle. You can imagine if I'm the tibial tubercle and I'm right in the middle where I should be, and here's my patellar tendon, everything's straight up above me, right? Let's say I take a step over this way, laterally. Well, which way am I going to pull my kneecap if something goes bad? This way, right? So that's how we fix people. So if you dislocate your kneecap a couple of times, we do this treatment for it, usually braces and therapy and braces some more and all of that stuff. Strengthen your VMO muscle, which is usually very weak on people who have this because it's not strong enough to pull their kneecap in. So if that all doesn't work, you can do something called a lateral release. Has anybody ever had any of this in here? You had a lateral release? So that's what they do, right? They try to train it to where your kneecap pulls medially, stays where it wants to, because all of us want to go medial. If that doesn't work, you have a lateral release. You cut their lateral patellar retinaculum, and it allows it to slide over to the middle. That doesn't work. We do something called a Fulkerson osteotomy, and that's literally where we take where your patellar tendon comes down to your tibia, we cut that piece of bone out, and we shift it medially. We bring it over because if it's too lateral, it's going to let it, you can do all the therapy in the world, and it's not going to work. So that's super, super, I mean, you have to be miserable in multiple years of patellar instability for us to do that. That's a big, humongous surgery. Subluxation, dislocation, you guys know the difference by now. Subluxation is it kind of wants to come out a little bit. I always tell people it's kind of like if you came up on the top of the wall and then fell back in versus falling over the wall. So the dislocation, and people, and the hard part for you guys as practitioners, is people cannot tell the difference in these because what do they feel either way? They feel that something was wrong and then it fell back in place and it popped and now I feel better. So in their mind, it was dislocated and reduced itself. But that's what they call a subluxation instead of a dislocation. Acute dislocation, once again, deformity, empty trochlea, like that guy as you saw in the first picture. I mean, there's nothing there. Patella located over the lateral aspect of the knee, often in a flex position. That's why I said that's unusual that they had a picture of him in a extended position, because that's what you do to get it back in. Subluxation or reduced dislocation, once again, large joint effusion because they tore that medial patellar retinaculum. Medialized knee pain, painful range of motion with flexion. Quadriceps inability to straight leg raise often, so they can't do this laying on the table. Reduction, once again, pressure applied to patella in a medial direction as it's brought in passively back into extension. Should be reduced ASAP for patient comfort and apprehension. Not because it's something dangerous, because once again, they're going to be wigging out. Examination and apprehension test. So this is what we can do. And remember, all those people who just did this can happen a lot easier on folks like that. Doesn't mean it will, just mean it can. But what you're doing is if you take their kneecap, and you can only do this in a completely extended position, you're going to start pushing it outwards. And when you do, they're just like the anterior apprehension of the shoulder, they're going to start going, hey man, I'm getting uncomfortable. Please don't push it anymore. You're going to make my kneecap come out. Palpation of the femoral attachment of the medial patellofemoral ligament. So basically right where his thumbs are right there is right where that runs. So if you even touch that and they jump, that's more than likely what's going on. Mechanical symptoms during passive range of motion. Remember, these people, their kneecap is not going straight up and down like it's supposed to. Sometimes it goes up and then goes to the side. On yours, the one that had it repaired, did your knee, once it in full extension, it would kind of want to slide off laterally. And you can even watch them just sitting on the side of the table. They'll go like this and their kneecap will be going up, and then you go into full extension and it'll go over to the side because it's so used to going out. Radiographs, AP lateral with comparison views, Sunrise, Rosenberg views, vital. So you can see how shallow that is? So remember, this is concave, this is convex. So if this is not that concave, this guy's going hiking, right? He's going that way. He's going to the outside. Conservative treatment, so no lateral tilt on the Sunrise or internal or lateralization on the AP. No loose bodies on the x-rays. Make sure that they didn't tear something loose like an avulsion fracture. Just because their kneecap dislocated didn't mean that it didn't pull anything off with it, as we learned with some of the shoulder stuff. No loose bodies on the x-ray, so what we do is we put them in full extension, but I will actually give them 0 to 10 because once again, full extension is miserable for folks. 10 degrees you can still get in your car. So it's 0 to 10 degrees. You do that for 3 weeks, which allows that medial patellofemoral retinaculum or medial patellar retinaculum to heal. And then after that, we put them in something called a Healy-Weber brace, which is a little rubber bumper brace that sits on the lateral aspect of your knee, and we get them in therapy at 3 weeks out. Surgical chronic dislocation. These people are the guys that have done this like 15 to 16 times, not like once or twice. Failed conservative treatment with therapy, braces, and all that, or a loose body on the x-ray. Okay. We doing good so far? I know this is a lot more in depth and a lot more lengthy. Is everybody good? When you stretch it around or anything, or just plow through? She says plow through. All right, so patellofemoral joint. Diagram showing pelvis, femur. So this is where you were coming in earlier with the hips thing. So it's called your Q angle from where it goes right here, right? So they measure this whenever they're doing surgeries for these types of things. Patellar tendon rupture. This is where this is not, once again, this is something that's very, very uncommon, but it sure does hurt. Failure of the extensor tendon due to excessive loading on unhealthy or soft tissues. Middle-aged patients. These are the guys who are out playing basketball with a recreational league or pickup league or something like that. They have a resisted knee extension, excuse me. Also included quadriceps tendon ruptures. We fixed 2 of these last week, but that's the first ones we fixed in a couple of years. These are all things that you need to be aware of and you need to know how to test for, but once again, not as common. 48-year-old male, onset of knee pain and inability to perform a straight leg raise after jumping. So once again, it's your basketball players, it's volleyball players, it's anybody who's doing a lot of repetitive jumping and they're in their mid-40s like me. Difficult to fully weight bear, ambulate on the extensor mechanism loss. So what do they lose? They can't straighten out their legs, so therefore they can't make their legs stable anymore. So when they put their weight down on it, it's going to feel like they can't lock it out to stand on it. So they're going to feel very unstable in extension. Soft tissue edema and ecchymosis, absolutely. These things are huge. They look like somebody beat them to death with a baseball bat. They're huge bruises. Inability to form a straight leg raise. So once again, if you have somebody that has a torn quadriceps tendon and patellar tendon, they're not going to want you to bend their knee and see if they can straighten it. So they can't even do this. They can't even do a straight leg raise. They may be able to do it, but there's going to be this lag. So instead of having a straight, nice, pretty leg, like that, they'll go like this. They'll go, and you'll see them struggling, try to make it straight. They'll have an extensor lag, is what that's called. Palpable and visible defects. Normally, these things, you can honestly stick your thumb in them. It's super, super soft. So you'll go, okay, and you're feeling down and going down the quadriceps. I'll usually just run my hand down, and you'll literally feel your thumb fall in a hole. It'll just go right down in the middle. Same thing on the top, same thing on the bottom. So any kind of a laxity, and they can't do a straight leg raise, which I'll show you on the exam. That's the first thing I have them do, is lay down and do a straight leg raise for me. For this very reason, you gotta look at all this stuff. Workup, AP and lateral x-rays are probably not going to show a lot, except for, now remember, it's a play of tug of war, right? So if my quadriceps tendon is working and my patellar tendon is not, it goes up like that. That without any kind of a injury, that would be something like a patella alta. It's up high, and that's actually a patella alta would be up here somewhere. But you can see where there's no opposing force. Quadriceps pulling the kneecap up, there's nothing to pull it down, so they tore their patellar tendon. And then on the AP, you can't really see anything unless the kneecap's sitting high. Because remember, your trochlear is right here, so if your kneecap is sitting up here, there's something not right. Patellar malalignment, MRI may be helpful on partial ruptures. To me, if I stick my thumb down in a hole on their knee, that's not normal, so I'll put them in an extension brace, flexion extension brace locked out from 0 to 10 degrees and go get an MRI. Often a simple clinical diagnosis it is, but once again you have to see the severity of it. Is it a partial tear? If their kneecap looks like this, there's no partial anything, it's torn. Refer them to us for surgery. These are all surgical injuries, remember that. A rupture of your quadriceps tendon or the patellar tendon, any rupture of the extensor mechanism is a surgery. There's no way around that unless you're just super old or super sick, and you literally can't undergo the surgery. Okay, because otherwise you can't walk. Osgood-Schlatters disease, this one's hard. Remember when we were talking about the shoulder and we were talking about little Billy with the clavicle fracture and you're like, oh my gosh, there's no way that this is going to stay okay. These are hard because you have an adolescent, because their growth plates are still open, and then basically they have this, this right here. Well, to the untrained eye, that looks like a fracture to me, right? So then you've got mama coming in because their emergency room doc or their primary care physician has already given them this x-ray, and they've gone home and looked it up on Google, and they see that this is a fracture, and it hurts, and it's there, so therefore it's a fracture. Because remember, tenderness palpation over an open growth plate is a what? Fracture until proven otherwise, right? So that's the hard part about this. Now, if you think about it though, is that that's why you have to discern this between patellar tendonitis, between a fracture of the growth plate of the tibial tubercle there. So traction of apophysitis, the tibial tubercle as an adolescent. And then remember, the reason we get Osgood-Schlatters is because sometimes in our body things don't all grow the same rate. So if my bones are growing at a different speed as my tendons and my muscles, what happens basically is your patellar tendon takes this guy right here and pulls him up like a car hood because he has not grown fast enough yet to lengthen out. So this will go up, and now your body says, wow, there's all this space right here between these two bones. What should I do with it? I'm going to fill that with a bone. Now, who has Osgood-Schlatters? Nobody? Really? Nobody has? This guy does, right?
Back in the day, but not anymore. But I've
Well,
got bumps.
But you still have the bumps from it.
Remnants, yeah.
Yes. So that's the thing, is you can look at anybody and tell if they've had Osgood-Schlatters or not because they have bumps on the front of their knees. If it's straight down from their kneecap, you didn't ever have Osgood-Schlatters. So one thing he said that's partially correct and incorrect is you do outgrow Osgood-Schlatters disease because then you stop growing. Your bones heal and they fuse. So you can't have it anymore on you can't have Osgood-Schlatters on an adult. You can have previous Osgood-Schlatters as directed on the x-ray. So you see this bump right here? So anybody who has that bump right there either has a new injury or they had old Osgood-Schlatters. So once again, own ossification insertion in the center, maybe patellar tendon or disrupted Osgood tibial tubercle. I don't know why this got worded jumbled like that. I think it was through the computer there. But basically it's that, is whenever the osseous centers don't keep up with the extensor mechanisms and the overuse. Usually this is what they call kind of like a jumper's knee, or I'm sorry, jumper's knee is patellar tendonitis. This is somebody who does a lot of jumping or does a lot of kneeling, does a lot of squatting. Wrestlers can sometimes get this just because of that, because it's a chronic repetitive activity placed on an immature skeleton. So once again, it will be hard for people to discern between, is this Is this injured or is this painful because I've done something to it, or is it painful because it's a fracture? And once again, if on the fractures, you'll sometimes even see a line that goes through there, frontwards or backwards or whatnot. But if it's true Osgood slaughters, you don't do anything with them. You just tell mom it's going to be okay and do secondary treatment, icing, anti-inflammatories, formal physical therapy. Painful anterior knee on adolescents, most often male. Inflammation at the calcification center on the tubercle, as we discussed before, able to perform a straight leg raise. So these guys, remember, they still have full range of motion. They actually probably have full strength. It's just uncomfortable when you resist their knee extension. They're often atraumatic. This is used to over chronic use and condition. Basketball players, volleyball players, pole vaulters get this all the time. Inability to kneel on the affected side due to pain. So work up again. Once again, clinical diagnosis. You take an x-ray. A lot of times, if you walk into our clinic, I don't care what's wrong with you, you're getting an x-ray, because we have to prove that. There was a story that I had heard about a guy that was there before me, and he forgot, and this lady said, look, I'm down on my luck, I don't want x-rays every time. It was actually ended up being of her husband. And he had a tumor in his shoulder, and that's why his shoulder hurt. But due to cut cost for the patient, they didn't ever x-ray his shoulder, they never found the tumor. So my point is that when people come in and they get all bent out of shape about having, well, I just got x-rays at the emergency room, why can't you just look at those? Well, I don't work in that emergency room, so unless you bring them to me, I can't see them. But I'm not going to not shoot an x-ray, because if I do, if I don't do that, that's negligence on my part. I did not look for something that could have been a tumor or a fracture or something like that. You're smiling, what are you smiling about? Nothing, just smiling in general, happy. Okay, I have a lot of my talks. So clinical diagnosis, once again, I'm going to go ahead and x-ray him, because you're going to have to see if there's this avulsion fragment or something like that. So once again, that's whenever we would do something more. So this, Osgood slaughters, right? This, okay, now let me ask you this, is this Osgood slaughters? What's the one thing you can tell me about that bottom x-ray that would tell me that that is not current Osgood slaughters? It's an adult. The growth plates are fused. Remember, like I said, you can't have Osgood slaughters disease, active Osgood slaughters disease in an adult, because their growth plates are healed. This is old Osgood slaughters. Okay? Same thing there. So once again, these things are very, and you'll get, I had one of these last week, I had one of these last week, and I haven't had one of those in a while. But even that's an adult. See, there's no, well, it's a crappy x-ray, but there's still no growth plates visible there. So once again, that's not Osgood slaughters. It's old Osgood slaughters. Reassurance to patients, this is self-limiting condition, same as patellar tendonitis, that will nearly all resolve without further intervention. Symptoms are on a broad-based spectrum. Activity modification is key. I have a philosophy, just like my 5 things that we offer people, ours is a limp or not limp. If they'll say, but yeah, but can I've got this thing coming up, can you do it without limping? Well, I don't know. Well, and then I'll usually have them stand up and try. If it's basketball, I'll have them try to jump. Can you do that? No, that pretty much hurts. Well, then you're not playing basketball. Don't make it so hard that there's this big, long mathematical equation on whether they can play sports or not. Basically, I'm going to say, if you're a runner, can you run without limping? No, I don't know. Or if they even hesitate, that means they're not confident. If they're not confident, they're not going to be able to do it. So we base all of our return to sport is either based off of protocol because of a rotator cuff or an ACL or something like that. Like if you have your ACL fixed, you're not playing sports for 6 months. I don't care how you look. I don't care if you're doing back handsprings down the hall at 4 months. You're not playing sports until 6 months, until you prove to me that everything else is good. Let me tell you something else about the ACL refest. I'm going to jump back. This is pretty important. They did a study one time on high school and collegiate athletes. And they found, because everybody always gripes about going to therapy, like I said before, they did this study, and it's called the 85% rule. And what they show is, if I have my right ACL fixed, is at the time that I dismiss them to go play sports, if my hamstring and my quadricep are not 85% as strong as my contralateral leg, there is a high chance that I will tear this ACL again and or tear the other side because the demand pushed on this. And I have seen it with my own eyeballs. It was a girl out of Chandler, and she was a junior. We released her on Friday to play sports on her ACL that she tried to cut corners on and didn't want to do the therapy. She went back and played a high school basketball game that night and tore her left side. So whenever we kind of gripe to people and have to beg people to go to therapy, that's why. So that's a good fun fact. So 85% is strong on your dominant or on your surgical leg before they get to do that. And if that takes 6 months or 6 years, you still don't let it play. Once again, activity modification, if it hurts, don't do it. The golden rule in life. Rice, anti-inflammatories, patellar tendon straps for symptomatic relief. Once again, surgical indication, non-union or a fibrous union of the apophysis. After skeletal immaturity, once again, I can't remember the last time we did one of these. This is book stuff right here. Chondromalacia patella. So remember, the chondromalacia, chondro means the articular cartilage, Malaysia means softening, right? So softening and fissuring of the articular cartilage on the back side of your kneecap. So everybody right now that's sitting cross-legged, just put both feet flat on the floor. It is kind of cold in here. A lot of you ladies have towels or blankets. Put your hand on your kneecap and then straighten it out. And then let it back down. And then do it back again. Just do it a couple of times. How many people feel a little bit of a, like a sandpapery kind of a...
I feel a pop.
Welcome to Chondromalacia. You all are sufferers. This is a support group. So basically, this is what this is, right? More common in adolescent females and young women due to malalignment of the patella and the trochlean. We've already discussed how that can work as an anatomic invariance. Increased Q angle, once again, your hips theory. There you go. That was very, very smart of you to say. And then quadriceps weakness. Once again, these people will come in, and it's not a, I was injured. It's not a, I got hit by something. This is something that's been brewing. It's been going on for months, and no matter what I do besides not running, it bothers me. No injury ever occurs, but now she has occasional swelling after activity and a grating sensation behind her kneecap. Now, just because any of you who felt that, raise it up again. Oh, it's pretty high, actually. It's a lot of people. So the thing about it is that mean anything? No, because how many of those same people that raise their hands, how much does it hurt? Who has pain with that? Nobody, right? So guess what we're going to do about it?
Nothing.
Nothing. But whenever it starts to hurt, that's when we worry about it. I don't know if I said this before, but popping with pain, we get concerned about that. If you come in and tell me your knee's popping and I ask you if it doesn't hurt, great, so does mine. Go have a good life. So there's that. Anterior knee pain, chronic in nature. Remember, this is not an injury. This is stuff that happens over time. Grinding sensation or grating sensation, difficulty with ascending stairs. That's what they'll come. They'll come in, they'll say, man, every time I walk up and down stairs, everybody can hear me, or if I can feel it grinding and all of that stuff. Going down a decline. So remember, in terms of mechanics and physics, it is harder for you to go downstairs than it is to go upstairs. That's why I think Stairmasters should all be put in a big field and burned. Because that's what causes a lot of my questions, is people who go to the gym and they want to do the Stairmasters. Girls want to do it because it kind of lifts back here a little bit. And it's not good on your knees. Going up and down stairs is not something that should be done, in my professional opinion, for recreation or exercise. All those people running the bleachers and stuff, is it a great exercise? Absolutely. Is it terrible on your knees? Absolutely. I'd rather you do elliptical ride or something that has no impact. Elliptical, rowing, swimming, even jogging and running, I would rather do biking. Because whenever you start getting older like me, all the stuff that sounded like a good idea when you did when you were a teenager, you're like, I wish I hadn't kind of done some of that. So I don't do anything impact anymore. I don't run unless somebody's chasing me. Exam findings, once again, patellofemoral crepitus increases with active range of motion, painful squatting and or duck walking. Once again, you can do that, but your patients look silly, first of all, walking around the room. And if somebody comes in, they're like, what are they doing there? No pain with palpation of patellar tendon and lack of medial shelf and or plica. Does anybody know what a medial synovial plica is? So this is one that I don't think is covered in this. I'll come back to that. Somebody remind me that when we get done. Chondromalacia patella, imaging not helpful because once again, you're not going to see it because can you see articular cartilage on an x-ray? No, you can't. So when you see bones, you're seeing the bones. You're not seeing articular cartilage. The way that I describe articular cartilage to our patients is, you know those little laughing cow cheeses, right? So you guys laugh, but I swear you'll use this stuff. The wax is not the cheese is not the wax, right? You don't eat the wax. You can, but you shouldn't. So the thing about it is what does the wax do? It protects the cheese, right? So whenever you have chondromalacia patella, when you have the startings of arthritis, that's what it is. You've always seen or heard of people grading arthritis, like they've got grade 1 chondromalacia, grade 2 chondromalacia, grade 3, grade 4. Does anybody know the different grading systems for chondromalacia on the knee? I don't know if I have it on here or not, probably not. So the way that I describe it is grade 1 is a softening. Grade 1 is that wax on the outside softening, right? It's kind of, back in the old days when people used to have headliners, the headliners would drop down and it looked like a pillow that you could kind of poke like that. That's grade 1. Grade 2 is it starts to split. It looks like dried mud on the desert floor. There's no rhyme or reason, it's just all split. Grade 3 is that splitting starts to look like shag carpet. If anybody, they call it a crab meat appearance or a shag carpet appearance whenever you look it up in the books. And that's what it is. Those splits have now started to do that. And then grade 4 is all of that's gone and now I can see your cheese. If I can see your cheese, you've got arthritis. That's grade 4 arthritis. Okay? So once again, is it silly? Absolutely. But will your patient understand? Absolutely. Because people don't get the difference between articular cartilage where one stops and one starts. And that's an easy way to tell them, look, your articular cartilage is protecting the end of your bone. Once that's gone, and the degradation of that is the definition of osteoarthritis, right? Everybody cool with that? A little sidetrack, but tuck that one away for later. Imaging not helpful because once again you can't see it. Patella alta, patella baja, lateralization of patellar tracking. So anything that doesn't keep that balance, kind of like the tires on your car balanced, if it's not straight in the middle, it's going to feel funny, and whenever it rubs, it's going to start putting more pressure on that articular cartilage. Conservative, exhaust physical therapy. This is not a hurried up thing as far as how you got it. It's also not going to go away very fast. It may take months to improve your symptoms. Activity modification, once again, that basically means if it hurts, don't do it. Anti-inflammatories and analgesics and bracing, once again, if you have the patellar maltracking. Surgical, once again, is if none of this works over and over and over and over again, but I can't remember. Now, this is one thing that I will somewhat tell you, and this is a hard part for me in my daily activities, is because whenever people come in, there will be a lot of orthopedic surgeons, and these people will come in and I'll say, hey, my name's Travis, I'm Dr. Olson's PA. I was looking at your x-rays and you have some pretty good arthritis in your knee. No, I don't. Well, okay, so why do you not think you have arthritis? Well, Dr. Bob, or let's use Dr. X because there actually is a Dr. Bob. Dr. X, he, about a year ago, he went in and he told me he cleaned out all my arthritis. So it's kind of impossible that I have more in there. So whenever physicians, and especially orthopedic surgeons, and it drives me nuts, is because they say they cleaned out my arthritis. If we could clean out our arthritis, we would just keep cleaning it out and nobody would ever have to have a total knee replacement again, right? And that's what I tell our patients. I said, if they cleaned it out, I wouldn't be showing, and I'll print off their x-rays and go, here's your arthritis, it is not gone. Now what we can do is we can do something called a chondroplasty, and so once again with crappy analogies, I say it's like polishing a rusty car. The rust is still there, you're just trying to make the surface a little bit more smooth so that when you're walking in your everyday activities, it's not as bad as it could have been, it doesn't fray as much. So we can do this chondroplasty, but we only do that if we're in there for another reason. If you have a meniscal tear and you're my age and you go in there and there's some startings of arthritis in there, I've got chondromalacia. Dr. Olson will trim that down and try to smooth it. Do I still have arthritis at the end of it? Absolutely I do. That's why people have to get all these different types of injections. So you cannot clean out osteoarthritis because remember, the definition of arthritis is there's not enough stuff in there in the first place. Cleaning out to me means when my wife grabs me about my side of the closet and I have to debride it, I have to get stuff out of it to make it clean again. Well, arthritis is where there's not enough stuff in there in the first place, so how am I going to clean that out? It's physically impossible. And it drives me nuts when they say that. Patellar realignment, that goes back to the whole Fulkerson osteotomy, too much for patellar chondromalacia. Plica syndrome, so this one's a hard one. This one is a hard one, so I want you all to write this down because I don't know if I talk about it or not, and we'll get into the arthritis. Plica syndrome presents just like a medial meniscal tear. You'll have a young, active, healthy athlete. They will come in with mechanical symptoms, popping, locking, clicking, catching, usually one-sided. Once again, going back to the meniscal tear type thing. It's almost always medial. You will swear up and down about your house that they have a medial meniscal tear, and then you'll go get an MRI, and it'll be normal. And then they come back and you go, hey, good news, MRI was normal, I'm glad everything's going good, let's keep doing what we're doing and let's go get you in some therapy. They come back after 6 weeks of therapy. Hey, how you doing? Still got the same popping, locking, clicking, catching. It's still very uncomfortable. I can't do the stuff I want to do. I know, but gosh, your MRI was normal and I gave you anti-inflammatories and you went to therapy. Medial synovial plica, so everybody knows that all of our joints are inside of a giant water balloon, right? Your synovium. And what a medial synovial plica is an extra redundant strap of that thing. So it's kind of like this thing on your hand right here, right? So this isn't totally necessary for our survival, but it works out occasionally. But imagine if that wasn't there. This is what a medial synovial plica is. So I always tell our patients is if you've ever actually made a pie, like made one and not bought it, there's always dough left on the side. So what do? You get your finger and you go around it like that. So imagine if you just flip that inside. It would be a redundant piece of that plica. And what it does is, if this is your femur, and this is your medial femoral condyle, this is your medial synovial plica, it does like that, and it rubs on it, and it hurts, and it gives you symptoms of popping, locking, clicking, and catching. So anybody who has mechanical symptoms consistent with a medial meniscal tear and a normal MRI who fails conservative treatment, you have to start thinking about this. So what do we do in our office? These people will come in and I'll say, okay, so let's sit down. And sometimes it's always good just to sit down and back up a little bit. Okay, so you came in, you didn't have an injury. Nope. Medial sided pain, mechanical symptoms. Yep. Got an MRI? Yeah. Normal? Yeah. Went to therapy, did the icing, anti-inflammatory cream, and activity modification. Yeah, I did all that stuff, and my knee's still popping, clicking, and catching. What do? I give them a steroid shot. Because A, it's got lidocaine in it, and B, it has steroids, which is an anti-inflammatory in it. And I don't care if they only get better for about 7 minutes, it tells me that the problem that they're having is intra-articular. Because if I give you an intra-articular injection and it doesn't help anything, well, it must be extra-articular. Remember, lidocaine, even if you go to the dentist and he numbs up your cavity, it's still going to feel better until the lidocaine wears off, right? So that's the whole thing about it. So that's a plica syndrome. So then what do? I give them a steroid injection and I bring them back in a week with Dr. Olson. And then he'll walk in the room and say, hey, what do you think? Did that shot help you? Yeah, you know what? For about 3 or 4 hours, that shot really did a lot for me. Or, no, that shot didn't do anything at all. If they say, yes, that helped me, we go scope their knee because they've got a plica. And I can't remember the last time that we thought somebody had a plica with that protocol and they actually didn't have one. It's very rare. The only other thing that can mimic that is something called a fibrotic retropatellar fat pad, and that's, we won't get into that one. Osteoarthritis of the knee is once again this subtopic. So here we go. Osteoarthritis. Address causation and location, chronic degeneration of the articular cartilage and meniscus. I know I just went off on a tangent about arthritis, so we'll kind of skip through some of this. Post-traumatic or post-surgical changes, location medial, lateral, patellofemoral. So, whenever you look at an x-ray of the knee, you look at the medial joint line, lateral femoral joint line. So the lateral, these two should always be equal, medial and lateral femoral joint line. So now look at this one. Can you guys see that far? See how wide open that is? See how that's not? So this is what arthritis looks like. Now, is this terrible? No, that's probably moderate, maybe borderline moderate to severe. But once again, so your joint lines should always be equal when you look at them for the most part. That one's not bad, but it's still on both. And that's the other thing too, is always have them standing. If they're laying down, their joint's not going to be compressed, so you can't tell joint line measurement on there. Post-traumatic arthritis, obviously post-surgical changes, non-operative management of the ligaments injury, fracture related. So anytime that you have post-surgical changes, like if they've had a big tibial plateau fracture, you can imagine that guy that had the terrible plateau fracture on the right, that dude's going to have arthritis. He changed his joint. He changed his leg for the rest of his life. He's going to have a higher chance of having arthritis versus somebody who didn't. Non-operative management of a ligamentous injury, what did we say before? If you have an ACL tear and you leave it alone, your mechanics are off. So you're going to start rubbing stuff that shouldn't be rubbed like that. And then fracture related is what we've talked about. So once again, look at this one, right knee. That's a sunrise view. They've got a little bit of a spur there, but otherwise this joint space is good. Look at that joint space. It's not good. Look at that knee. Not bad, still arthritic. Look over here on the lateral femoral condyle, lateral tibial plateau. They don't have any joint space. Treatment of osteoarthritis and degenerative joint disease. So everybody knows the difference in osteoarthritis and rheumatoid arthritis by now, right? Okay, good. Because I don't like rheumatoid arthritis. That's why they have rheumatologists. Non-operative, anti-inflammatories, risk and benefits, chronicity, injectable corticosteroids. Remember, I told you guys the rule of 3, right? I told you that we won't ever inject someone's knee. So if it's your right knee, I'm never going to give you more than 3 steroid shots unless, honest to God, you're 90 years old, you're never going to have surgery, and you just don't give a damn if I keep giving you injections. But I'll still, even on those people, I will dictate. They have chosen to continue with steroid injections. They do understand that there's a risk of infection because of chronic steroid injections, and they also understand that there's a risk of weakening of the good soft tissues in their knees. So you have to document that if people wish to continue, because you will have people who only want steroid shots. Old school people love steroid shots, because back in the day, that was very common. The late 70s, early 80s, and even before then, everybody just gave steroid shots like they do aspirin. It wasn't a big deal back then, but now that they've started to notice that these are not as good as they said they would from a chronic standpoint, like I said before, we do the hyaluronic acid. This is things like Hyalgin and Suparts and Synvisc and Orthovisc and things like that. That is basically a motor oil for your knee. It's basically a replication of the normal joint fluid that you have in your knee, and we're just basically putting it back in there, but it's a little bit thicker. It coats the bones, it doesn't treat them. So the best analogy I have for this, whenever people are asking about what does viscosupplementation do, does it cure your arthritis? Absolutely not. I tell people it's like your non-stick pans at home. You have the Teflon on them. Once the Teflon starts chipping off, what happens? Your egg starts to stick, right? Because of friction. That's what causes pain. So if you can either do one of 2 things. You can either buy a new pan, or you can put cooking spray on it. So whenever I put cooking spray on my pan, does it make the Teflon grow back? No. What does it do? It decreases the friction. And if I can decrease the friction, then I can decrease the swelling, which decreases the pain, which increases range of motion. So when we give them these hyaluronic acid injections, we are not rebuilding their articular cartilage. We are simply making it slipperier, so it doesn't stick and it doesn't hurt. And these work very well. Roughly 70–80% of people get better with those, depending upon how long. You can get those insurance companies pay for you to get these every 6 months. Physical therapy, basically take something and tune it as good as you can, see how well it runs. Bracing, we do have things called medial unloaded braces. The vast majority of people, when they have osteoarthritic changes, they have it on their medial joint line. So what they do is this medial unloaded brace literally puts a mechanical pressure on it to open it up. It keeps it from rubbing on itself. Activity modification, basically, once again, if it hurts, don't do it. Surgical management is an arthroplasty. Now we actually do 3 different types. So this is a total knee arthroplasty because it involves a lateral and medial joint line, or medial compartments. We actually do one called an Oxford knee replacement, which when most people only have medial compartment osteoarthritis, we can only replace the medial aspect, and it's called an Oxford or a partial knee arthroplasty. And people do very, very well with that, and it only takes about half the time to get over than a total would. And then we can actually replace the patella too, the patellofemoral osteoarthritis. If they truly just have that, we can do that as well. We actually just did a total toe the other day too, and it was really cool. So if you have these people who have bad arthritis in their big toe, we can actually do a total toe joint replacement now. And the cool thing about that thing is there's no rehab. You have surgery once the incision's good, go have a happy life. It's amazing. Pearls and parting shots. Always compare bilaterally, palpation, special test. Even if radiographs are needed, do it, both sides. Effusion never lies, intraarticular pathology. So if something is swollen and red and tender and fat and they didn't have an injury, you have to assume there could be an infection there, right? Acute injury and effusion, and hear and feel a pop on their knee, 80% chance that it's their ACL. Based on that right there. A deceleration injury, my knee swelled up immediately and I felt and heard a pop, or my friend that was playing soccer next to me heard something. You start betting money that it was their ACL. And history. Once again, I think by now that if I told you guys once again, planning or pivoting on a planted foot sounds like a what tear? Meniscus tear. If somebody comes and hits me front side to back side and I was sitting here standing still, I probably tore my PCL. If I'm a defensive end playing like this and the pulling guard comes and gives me a valgus stress, it's my PCL. And if I was a running back and I have my leg out like this and somebody hits me from the inside out, it's my right. So you see how this stuff, and it's only been 2 hours and you guys already know how to do all that stuff. So once you hear these things, and believe me, after 17 years, it's very, very easy to get fooled. You just have to stick with what you're supposed to do. Find a routine. I'm a big rut person. Being my type A personality, I love controlling things. And so I love being in a rut. So it may sound mechanical, and the gentleman in the back there, he's come and shouted me before you were even in PA school, right? I mean, how much of this stuff that I'm saying did I say 50 times that day you were with me? All day, every day. All day, every day, you say the same thing over and over. And you may say, well, that kind of sounds boring. No, it's not. It just makes you good at your job, because then you can help people get better, which is the whole goal, right? To get our patients better. So if you want, oh, I didn't know we had these. Let's just go through these together real fast. Well, you guys have already done all this. Okay, so any questions other than that? And if you want, I will show you how I do my knee exam. Any questions about the knee so far? I know it's a lot. Sorry, this one was about twice as long as the last one. Questions or concerns? Yeah, flip on the light if you want. Hey, since you're standing, why don't you come lay down up here for me, please? Teach you to go to the bathroom. Just lay down with your head down there, please. Okay, so this is my knee exam. So remember, I told you everything comes in and work. Can everybody see? If you can't see, stand up. All right, so this is mine. I'll kind of do it because I usually have my back to you. So if I come in and say, hey, once again, hey, my name's Travis, nice to meet you, I'm Dr. Olson's PA, find out what they did. So this is the exam. So the first thing I'll do is have them flex your quad. So make a muscle for me. No, just make a muscle. Just make a muscle. So that's a quad set, right? Now do a straight leg raise for me if you don't mind. Okay, so what do we know works? Just right there. Come on, we already went through this. What did you say? Your extension, but what? What do you have to have working to extend her leg like that? So you took it way nerdy real fast. Let's make it easy. Her quad works, right? So if her quad works and her leg straight's up, here, put this down. Now, come up like this. So what do we know right by looking at this? It works. This works. This works. This isn't broken, more than likely, but it could be. And this works, right? Because when we talk about the lag, right? So if she brings her leg up like this, and you can see her leg quivering, and she's trying to get it straight, you know she's torn one of these two things, right? So that right there shows you how to do that. So okay, so let's do this again. So make a muscle for me. And now do a straight leg raise. Okay, come back down, please. All right, so now if you don't mind, I'm going to bend your knee back. I'm going to put it at about a 90-degree angle. Okay, so this is the way that I do things. Are you comfortable doing this, by the way? I kind of just volunteered you. So
I'm just really cold.
that's okay. That's okay. So a couple of things. So what do I start off with? So remember, inspection. Is it swollen? Is there anything wrong with their bruising or anything like that? Is anything malaligned? Is there a kneecap over here, right? So what do we do? So I test my patellar tendon first, medial and lateral joint line, MCL, LCL. Now remember whenever I said earlier, if you're doing something and then you're concerned about it. So like let's say that I'm concerned about her LCL. So if I do this and she goes, whoa, that's super tender. Well, now I'm going to go back and I'm going to go, all right, is it right there, or is it more at your joint line, or is it right there at your fibular head? And then they'll say, oh, it hurts more down bottom, and then you go from there. So once again, so patellar tendon, medial joint line, lateral joint line, MCL, LCL. Your pes anserine bursic, if you can kind of lay it over there, is right there. So I always tell them, my hand is covering your knee joint. Is your pain inside your knee joint, or is it right here below? Because remember, those three tendons start in her groin, and they come over and they attach literally right there. And you won't see a big bump on it like you will with patellar tendonitis. It'll just hurt real bad. And so they'll say, well, my knee hurts, but and then when you push like that, they will come unwound because it hurts a lot, but you can't see it. Okay, so once again, patellar tendon, medial, lateral joint line, MCL, LCL laxity. And so right here is whenever we'll do the ACL. So a lot of times if they're on a table, I'll say, okay, I'm going to sit on the side of your foot so that they can't move it. And so what I'll do is, so you go ahead and get yourself in position for the anterior drawer and the posterior drawer. And if this has been covered with you guys, stop me because I know Sally did some of this. So what you'll do is, see how right now her leg's straight up and down? She's not relaxed because she's going, I've met this guy twice and now he's going to yank on my knee. So what I'll do is, and don't use the word jiggly, guys, this is not go over well. So what I'll do is I'll say, hey, why don't you try to relax your hamstring? Because remember, if she's going to guard with her hamstring. So she's going to pull this backwards. So I'll kind of do like this. I'll say, let this just loosen up. I said jiggly once, and that's it. So let this go. And as soon as she relaxes, so relax for me. Just let your leg fall off the table. That's your anterior drawer and posterior drawer. It is not this, right? I mean, you're not skiing on it. It is literally that fast. You're just going to let her go, and as soon as her leg drops forwards and backwards, there's your anterior drawer and posterior drawer. Now, for my ease of use, this is what I like to do with this. So we're already at this level. Remember, we don't want to straighten them and bend them all that much. So what I'll do is from here, I'll bring my hand up. So their foot is cradled in my hand like this. Their foot is right here. And so what I'll do, so this is a laying down McMurray. So remember, you're going to put them in a valgus stress with their foot externally rotated, which tests for which meniscus. Can you guys see? Am I like blocking your way? Which one's this? Medial, right?
Yep.
So what you do is you put them in a valgus stress, toe out, and you come all the way down. A lot of people you will see on the videos just do this. This is doing nothing. And I can't tell you how many times that I have gotten to about right here, and you'll feel and hear a pop, and they'll go, oh, that's it right there. There's your meniscal tear. So once again, for the medial meniscus, toe externally rotated, foot externally rotated, valgus, and you don't have to push, just lay your hand on it. And come down, and all the way into extension, and then the same thing for the lateral, toe inside, a little bit of pressure, and come all the way down into extension. There's your medial and lateral McMurrays. So once again, for just once again flow, then I put them up under here, put my hands here, I'll put my index finger on their MCL and LCL. You'll do varus and valgus stress at 0 degrees, varus and valgus stress. See how much easier that is? Can you see that from back there? So here, tighten your quad for me, like hard. I am not moving her at all, right? See, there's nothing except for her upper body moving. Now relax. See the difference? And that's just in her relaxing, and there's nothing wrong with her. So you can see how much easier it is. So me, with my hands. What?
You said nothing's wrong with me and someone giggled.
Oh, well, physically. Okay, so once again, medial and lateral. And so me with my hands, the way that my brain does it, and the way that I can do this with most people, is right here. You're already there. Remember, hip externally rotated, knee is straight, and then I can do allotments from here. You can also do it here, just by letting, so if she's on a table and not hanging off the end, I'll have her do this, because once again, it's hard for her to engage her hamstring, and this is allotments, just right like that. And that's a knee. So formally and fastly, we'll go make a muscle do a straight leg raise for me, please. Okay, back down. Now bend your knee back for me. Okay, just relax. Do you have any pain here? Or here? Or here? Nothing here, nothing here. And I'll say, okay, this is the inside, and this is the, or I'm sorry, I got ahead of myself. So if you will, just let your leg relax. As soon as she drops, anterior drawer and posterior drawer. It's that fast. Once again, don't pull. You're not going to see anything with this that you won't see with this, and you can feel hers popping. And then what you'll do is I'll say, okay, this is the inside of your knee and the outside of your knee. Let me know if anything bothers you. Is that okay? And that's okay there? Okay, if you will, relax for me. So once again, check your MCL and LCL at 0 and 30, and then let them down, rotate them out, and do your allotments. And you can feel them right like that. Now, if I was worried about something more, I would, of course, go back to that. And you can do the same exact thing with her sitting up. If you don't mind, flip over on your belly for me if you feel comfortable doing so. We'll show them Apley's. Okay, so an Apley's grind test. You know, they actually have this. Did you guys in your study of the shoulder, did you see them where they laid people on the side and they would do the apprehension test and shoving down? It's the same thing, right? You're trying to impinge something. So all an Apley's grind test is I'm going to push her leg down and then I'm going to rotate for, so if it's like this, which meniscus did I tear? And what about this? That's an Apley's grind test. Now, do you see a whole lot of difference in that in the McMurray's? Me neither. That's why I don't really do it. Because once again, if I'm suspicious, I'm going to be suspicious on her history. Planted on a pivoting foot, or pivoting on a planted foot, and mechanical symptoms. Popping, locking, clicking, catching. Flip over on your back one more time. So whenever I said I would describe the pivot shift test to you, a pivot shift test, once again, is only usually done because people won't let you do it on them while they're awake. A pivot shift test is you take them in full extension and you put them on a valgus stress, and what you'll do is then with that same valgus stress, you start bringing them up into flexion. And what will happen is, and we usually do this once again whenever our MRI says there's an ACL tear, we get in surgery and there's no ACL tear. We're like, the MRI says it, we'll throw the pictures up and then we'll do a pivot shift on them. So if a pivot shift, if under anesthesia, she's completely relaxed, right? I mean, there's no muscle tension whatsoever. A positive pivot shift is, once again, starting in full extension, flexion, and you start bending their knee. And if her ACL is torn about right here, it'll go boop, like that. It'll just pop out. And that means that her ACL is torn. That's a positive pivot shift. If it doesn't, like hers is not torn, and we sit there and go like this, and it's nice and smooth all the way through, it's a negative pivot shift. If it is a negative pivot shift test on a torn ACL on MRI, we still want to fix her ACL because it's not mechanically unstable. That is something that we'll do better with non-operative means. You great? Questions or concerns about that? Pretty straightforward, right? So once again, find your groove, do whatever order you want to, and then just get good at it. Okay? Any other questions or concerns about the knee that I did not cover? All right. Well, you guys have been great. Thanks for letting me come talk.
Thank you.